ครับกับสวัสดีอาจารย์ทุกท่านนะครับแล้วก็น้องๆแพทย์ประจำบ้านต่อยอดสายอุบัติเหตุทุกทนนะครับก็ขออนุญาตกราบเรียนเชิญนะครับอาจารย์แล้วก็น้องๆทุกท่านนะครับเข้าสู่งาน Collective Review ครั้งที่4นะครับซึ่งงานนี้ก็จะเป็นกิจกรรมที่เราจัดทุกปีนะครับมาเป็นระยะเวลาปีนี้ปีที่4นะครับซึ่งมีเป้าหมายในการที่จะให้อาจารย์นะครับได้ร่วมนะครับชี้แนะและก็ทำงานกับน้องๆในการทำ งานนำเสนอที่มีเรื่องของงานวิจัยเป็นพื้นฐานนะครับและรวมถึงจะมีการทำหนังสือนะครับ collective review book นะครับซึ่งเป็นตำราที่ทางอนุสาขา trauma เราก็จัดทำอยู่ทุกปีนะครับในเบื้องต้นนะครับผมขออนุญาตกราบเรียนเชิญนะครับประธานอนุสาขาอุบัติเหตุนะครับรองศาสตราจารย์นายแพทย์ก้องเขตเหรียญสุวรรณนะครับกล่าวเปิดงานครับขอเรียนเชิญอาจารย์ก้องเขตครับ
ขอบคุณอาจารย์แพทย์นะครับอาจารย์นรเทพครับกราบสวัสดีอาจารย์บรรจงนะครับแล้วก็สวัสดีท่านคณาจารย์นะครับในอนุสาขาการบาดเจ็บทางออร์โทปิดิกทั้งออนไซต์และออนไลน์นะฮะแล้วก็สวัสดีน้องๆเฟลโลทุกคนนะครับพยายามจะทำให้มันไม่ใช่เป็นออฟฟิเชียลนะเจออาจารย์แพทย์ใส่เบรเซอร์เข้าไป ผมคิดว่ากิจกรรมนี้เป็นกิจกรรมที่ได้ประโยชน์มากทั้งกับผู้ทำและก็ผู้ฟังนะฮะครั้งนี้เป็นครั้งที่4ใช่ไหมครับอาจารย์แพทย์เราจัดกิจกรรมลักษณะเนี้ยเพื่อที่จะให้โอกาสกับน้องๆเฟลโลที่ที่มาเทรนในปีนั้นๆนะฮะได้มีโอกาสในการที่จะรวบรวมข้อมูลทางวิชาการเนาะต้องบอกว่าเป็นเรื่องที่เป็นฮอตอิชชูหรือว่าเป็นเรื่องที่มีการอัปเดตขึ้นมาเป็นเรื่องที่น่าสนใจนะครับในแขนงต่างๆแล้วก็ทำงานร่วมกันกับอาจารย์ที่เป็นที่ปรึกษานะฮะของน้องๆสุดท้ายก็คือมานำเสนอในวันนี้ก็เป็นการฝึกทักษะในการนำเสนออีกรูปแบบหนึ่งนะครับแล้วก็ท้ายที่สุดคือมีการเขียนหนังสือเนาะก็ถือว่าเป็นกระบวนการทางการเรียนการสอนทางวิชาการที่ครบถ้วนนะครับสำหรับผู้ฟังปีที่แล้วท่านอาจารย์บรรจงก็มาครั้งหนึ่งแล้วสำหรับผู้ฟังผมคิดว่าได้ประโยชน์ในลักษณะที่มาอัปเดตวิชาการนะครับเพราะว่าแต่ละหัวข้อก็เป็นเรื่องที่น่าสนใจเหมือนที่พูดไปแล้วน้องๆเองที่มานำเสนอเนี่ยน้องนำเสนอในเรื่องของที่ตัวเองเตรียมเนี่ยก็มีโอกาสมาฟังเรื่องอื่นๆที่เพื่อนๆเตรียมมานะครับอาจารย์เองก็เหมือนกันที่มาฟังก็ได้ประโยชน์ในลักษณะที่ย่นย่อเวลาแทนที่จะต้องไปอ่านหนังสือโอ้โหเยอะแยะมากมายก็มาฟังน้องวันนี้ก็ได้ประโยชน์เพราะฉะนั้นผมคิดว่าก็ถือว่าเป็นวินวินนะฮะทั้งผู้ฟังทั้งผู้พรีเซนต์ได้ประโยชน์หมดนะครับแล้วก็สุดท้ายก็มีโอกาสไปนำเสนอในที่ประชุมประจำปีของเราคือที่โ o แท c นะฮะก็ถือว่าเป็นกิจกรรมที่สานต่อกันมาเป็นปีที่4แล้วคิดว่าเป็นกิจกรรมที่ได้ประโยชน์ในภาพรวมอย่างยิ่งนะครับก็คิดว่าเป็นโอกาสอันดีแล้วก็ตอนเย็นถ้าไม่ได้มีติดธุระอะไรก็ไปร่วมงานเลี้ยงนะฮะที่เราจะเลี้ยงเฟลโล่ด้วยกันระวังเรื่องน้ำนิดนึงนะแถวนี้น้ำขึ้นลงนะวันนี้ตอนนี้ไม่ท่วมตอนขาไปไม่ท่วมขากลับไม่แน่นะฮะเพราะนั้นอัปเดตสถานการณ์ภาคพื้นด้วยนะครับ ก็คิดว่าได้เวลาอันสมควรแล้วนะครับก็ขออนุญาตเปิดกิจกรรมcollective review ในวันนี้นะครับก็ขอให้สำเร็จตามวัตถุประสงค์ทุกประการครับขอบคุณครับ
ครับขอบคุณอาจารย์ครับก็ในเรื่องของกติกาในการนำเสนอนะครับน้องจะเห็นว่าพี่ๆจัดสล็อตเอาไว้17นาทีเนาะน้องนำเสนอแค่12นะครับแล้วก็อีก5นาทีจะเป็นช่วงเวลาถามตอบจากอาจารย์นะครับก็จะมีคำถามนะครับคุณหมอท่านแรกพร้อมหรือยังครับไหนใคร number one เอ่ยไหวยังพร้อมยังนะโอเคนะเอานะโอเค
Good morning, Chairman and Co-Chairman and all participants. I'm Dr. Sirawit Valaipatchara from Pauwel Hospital. Today my topic is coracoid process fracture diagnosis and treatment. Before start, I would like to give special thanks to my advisor, Dr. Rahat Jariyapan. Okay. Okay. Before start, you must know that coracoid process is a lighthouse of the shoulder because itself has many ligament and muscles such as pectoralis muscle, minor muscle, and coracoidialis, short head or bicep, and four ligament that attach to it. So the injury of the coracoid like a fracture is very rare. Isolate fracture of the coracoid is less than 1% of all fracture and can associate with scapular fracture 3 to 13% and occur with the proximal humerus like 5%. So it's very frequently not detected and follow with the painful non-union. About the mechanism of injury has no consensus. Many literature they predict that coracoid process fracture has get it from direct trauma or indirect trauma such as superior translocation of the humerus and some avulsion fracture from the pulling of the muscle. State fracture has reported in the recreational hunter and tap shooter and cricket player. About the iatrogenic can start with the surgery around the shoulder, and the last one is pathologic fracture with primary bone tumor such as chondrosarcoma. So, if you physical exam the patient about the isolated fracture, you can palpate the coracoid tip, and it will tender at the tip of coracoid process. The patient will get the painful with shoulder abduction, flexion, and external rotation. About the non-isolated case, it's not associated with AC joint injury more than 58%, and the symptom of concomitant injury must mark the symptom of coracoid process fracture. After physical examination, about the investigation, first thing you must do is X-ray. If you suspect the coracoid fractures, you must send the Gaucher view. It is a true anteroposterior view and scapular wide view. And many literature suggest to send the axillary view because it can improve initial fracture detection, increase rate from 33% to 88%. This is for example the C the right side right picture, you can see that axillary view can give more detail in coracoid bed fracture. Next, about CT scan, it is a gold standard for diagnosis coracoid process fracture. It can give better visualization and give the detail of morphology and displacement of coracoid fracture. About MRI, we will send the MRI for state fracture or for evaluate some concomitant injury like a rotator cuff tear or elbow tear. This is compared X-ray with CT scan. You can see that in the a little bit displacement of X-ray picture, you can see more in the CT scan. After diagnosis of coracoid process fracture, the classification in about coracoid process fracture has many, but I choose only three that mentioned many times in the literature. First one is Okawa classification. They proposed in 1990. It's based on anatomic location of the CC ligament attachment and the relationship with fracture line. Type 1, the fracture line pass posterior to insertion of CC ligament, and type 2 is the fracture line is passed anterior to insertion of CC ligament. Next, ILIS classification they proposed in 1995 and divide to 5 types. Type 1 is fracture at the tip or epiphyseal area. Type 2 is fracture at the mid process. Type 3 is basal fracture, and type 4 superior extend to superior body of scapula. And the last one, type 5, extension to glenoid fossa. And in 2020, they create the new classification about anatomic 3D CT classification. It's based on CT scan. It's the first one that based on CT scan and used worldwide. They divide in 4 classification. Type 1 is apex fracture. Type 2 is big fracture. IT fracture of the base. And the last one, type 4, is comminuted fracture. About treatment of coracoid process fracture, nowadays there has no consensus. It's rely on recommendation based on level 4 and 5 evidence. The surgical treatment recommended in Okawa, Taiwan, or at least type 4 or 5, because these 3 types has high risk of non-union rate, about 45%, but there was no consensus in this recommendation because someone has non-union coracoid process but has no symptom, no pain, no significant symptom, something like that. And about the functional outcome, it's similar to the surgical case. The conservative treatment we do in the non-displacement or minimal displacement less than 1 centimeter without superior shoulder suspensory complex disruption. So we manage immobilize with arm sling and rehabilitation begin passive and active assist range of motion at 6 weeks. Union can occur in 6 to 8 weeks and the patient can return to sport in 2 or 3 months. Next, the surgical treatment. We have indication for surgical treatment for choice. First, coracoid fracture complicated by the author injury of SLC or the brain disruption scenario. Second, displaced iris type 4 and 5 fracture, more than 1 centimeter. And third, Okawa type 1 fracture with capuloclavicular dissociation. And the last one is symptomatic non-union after treat with conservative treatment 6 months. They have recommendation through surgery in epilepsy patient because epilepsy is one of the list in patient to be non-union. Another recommendation is athlete and manual labor. They suggest to surgery because they want them to get early return to activity, but no clear evidence and the outcome is compared to conservative treatment. Management of the surgical treatment. Many surgeons do the coracoid fracture via the orthopectoral approach, and they use 1 or 2 bicortical screw with washer. You can use 3.5 to 4 millimeter cannulated screw and rack screw. And the recommendation of screw orientation is 15-degree medial angulation and 30 to 40-degree posterior angulation. Another alternative treatment fixation is they use biocomposite suture anchor 6.5 millimeter. They insert the anchor suture in medullary canal of the proximal coracoid and use non-absorbable suture tape to suture the conjoint tendon and the distal part attached to the proximal part. When you surgery, you must careful about musculocutaneous nerve and coracoid clavicular ligament because it's many report has iatrogenic injury to them. This is example for post-operative fixation in fluoroscope and X-ray. After fixation, you must immobilize the patient 2 to 3 weeks and begin range of motion physical therapy. After that, union rate can occur in 6 to 8 weeks and return to sport in 3 months. About the concomitant fracture, many cases of coracoid process occur with injury around the shoulder, many literature has recommend to fix another fracture. After fix another fracture, then they see the coracoid process. The coracoid process can be reduced indirectly, and if it little displacement or non-displaced, you can treat with conservative treatment. So the direct fixation in this case for the coracoid process may not be necessary. Okay, the last one about the conclusion. Coracoid process fracture are rare injury. No clear evidence about conservative or operative treatment. The conservative treatment suggests in Okawa type 2 and ILS type 1 to 3. The surgical treatment has indicated in SLC instability, Okawa type 1, ILS type 4, 5, and symptomatic non-union. Both conservative and surgical treatment has excellent outcome. So when you treat the patient, treatment should be individualized and shared with the patient and the surgeon. Thank you.
Thank you. Any comment or question from the floor? Please, Dr. Panachol.
Please provide the information about the associated suprascapular nerve injury associated with this type of fracture of coracoid, especially for the base of the coracoid process fractures.
Because the nerve can pass supra sorry about supraclavicular nerve. Okay. When coracoid process fracture, many times can concomitant with AC joint injury and maybe coracoid fracture, and after that, the proximal part will superior translation and can detection to the nerve. And when surgery, many surgeons do the deltopectoral approach, or someone do the saber approach to the coracoid, and it can be iatrogenic injury in the second hit of the nerve.
My question is how about the incidence
Oh,
of the nerve injury?
sorry, I'm not sure that how many number, but they mention about the nerve, right? But about number, I'm not sure. Sorry.
So I have a question. So, you for epilepsy, you recommend surgery for the patient with epilepsy. So what is the reason? Because if epilepsy is the list of non-unions specifically to the coracoid fracture or
They mention in only one literature that retrospective about non-union fracture for the coracoid, and only list that specific is epilepsy about 30%. But I think the number of that paper is very low, around 20 to 30 patients. Because the coracoid process is very rare. The limitation is the number and the number of the patient. So it is just only one they recommend. But in the same reason that is rare condition, rare fracture, and always miss the act because the X-ray not clear like that. And patient come after with no significant symptom. It's not clear evident, but they mention. Yeah.
Thank you very much for your interesting talk. I have two questions. The first one is, what is the most common deforming force of the coracoid fracture? And the second one, after surgery, should we advise the patient to immobilize or to limit any activity to minimize deforming force causing displacement of the fracture?
For the force that get the deformity, the coracoid process associated with acromion fracture. AC joint injury and in the same condition that the gravity from your arm and your forearm pull down the distal part to the suggest that the patient will get the immobilization with arm sling to prevent gravity and the weight from his or her arm and forearm to prevent displacement. And about activity, they suggest to start range of motion at 6 weeks. 6 weeks they can do passive movement and assist active. Assist active is mean not over 90-degree flexion of arm and use another arm to help to rest the injury arm. Yes. And about return to fully activity and sport start in 2 or 3 months, individual in each patient.
Can I have one more question?
Last one. Thank you.
Yeah, thank you. Have you seen the surgical fixation of this coracoid fracture before in your life?
I think no. I'm not sure because just
No, just you
only-
haven't seen, right?
yes.
So my question is, because if you would like to fix the screw, you need to insert the screw really long to catch the base of coracoid base. The problem is how to reach the coracoid base, because every time you try to reach that, the clavicle will obstruct your surgical exposure.
About the approach, I have no experience, but in the literature they suggest to use the tower clip to clamp the distal part or use the joystick KY and maybe use and maybe release the pectoralis minor tendon and conjoint tendon a little bit to expose the bone. But if you want to fix the I'm not sure that coracoid process and the clavicle how
I will tell you in detail after we.
ครับ
You mean during coffee break? Thank you.
ครับผม thank you
Thank you. Okay. Thank you. Thank you for your excellent presentation. And I think I got the ring. So the first ring will be, well, it's meaning that you have 2 minutes left. And the last one will be ending of the presentation times, okay? The second topic, I would like to invite Dr. Shanya Klanwarin from Kakanan University Hospital. She will talk about the augmentation of the proximal humerus fracture fixation. The advisor is Dr. Patrakasem. Dr. Shanya, please.
Okay, so for my presentation is on the augmentation and proximal humerus fracture fixation. The proximal humerus fractures represent one of the most challenging injuries in shoulder trauma because they sit at the intersection of poor bone quality, complex biomechanics, and limited soft tissue envelope. Augmentation is not simply the addition of hardware or graft. It's the intentional reconstruction of the humerus's load-bearing architecture to restore stability, maintain reduction, and optimize healing potential. The fractures show a bimodal pattern. In young patients, this can be caused by high-energy trauma, which produces comminuted head shaft dissociation. In the elderly, fragility fractures dominate and is characterized by cortical thinning, parotic cancellous bone. The fixation in this group often fails without augmentation because the plate alone cannot restore the lost column support or provide reliable screw purchase. For the biomechanics, the shoulder behaves like a short cantilever beam. The medial calca acts as a compression column with the lateral cortex and the greater tuberosity functioning as the tension and rotational buttress. and the rotator cuff centers the humeral head during deltoid loading. If a fracture occurs, the plate substitutes for the lateral tension band. But if the middle column is deficient, the head then collapses into varus and the screws can toggle as well. So augmentation is about restoring this beam-like behavior with the medial compression, lateral tension, and to balance the rotational stability. Fracture typically happens through varus collapse during the medial calca deficiency with screw cutout from poor cancellous bone purchase or torsional failure with a greater tuberosity and the lateral wall when they are compromised. In severe metaphyseal comminution, the head can behave like a ball on a stick with essentially the head and shaft dissociating from each other. And the biological failure like avascular necrosis can also occur, especially if perfusion is lost and the mechanical instability persists. So these patterns set the stage for when we consider augmentation to be needed. For goals of augmentation, we want to rebuild the medial column, improve screw purchase, and fill the metaphyseal voids to restore the head-shaft relationship and to support the tuberosity healing to preserve the cuff function. And these goals will guide us through the choices of augmentation rather than from the fracture classification alone. Augmentation techniques can be grouped like this. So the extramedullary options such as medial calca plating or dual plating, intramedullary techniques such as strut grafts, endorsal plates or cages to rebuild the internal support, and the bone substitutes such as cements to improve the screw interface strength, and hybrid constructs and other biologic modulators. So for the medial buttress plating, so when the medial hinge is disrupted, lateral plating alone may not be sufficient enough. When we add the medial buttress plate, this restores the compression column, increases the actional stiffness, and reduces the varus collapse. This is particularly effective for cases with head shaft dissociation and fractures with comminuted medial cortices. So the goal is to create a balanced dual column construct without any excessive hardware bulk. For plate placement, you can place it on the anteromedial side, but you have to be aware of the anterior circumflex humeral artery, which runs along the bicipital groove. You can also place it posteromedially, which you can buttress the fracture from if the configuration requires it, but you have to be aware of the axillary nerve. And you can also put it endostally. So this is inside the cortex. This provides an internal column support with minimal soft tissue disruption, but the technique may be a little bit more demanding. So optimal positioning, you would want a orthogonal construct and a low profile plate, and you want to keep it posterior to the bicipital groove and minimize the dissection. This is another one. The lateral wall and the greater tuberosity are equally important because loss of the lateral cortex reduces actional and torsional stiffness, even if the medial calca is restored. So stability depends on both sides of the construct. So reinforcement can be achieved with strong cup to plate sutures, cerclage tapes, cancellous grafts under the GT, or any additional lateral plating in extreme comminution. For intermedullary augmentation, the goal is to restore endosteal continuity when the metaphyseal bone is hollowed out. By rebuilding the internal column, this prevents the head subsidence and varus collapse. So the first option is the structural bone grafts. The structural bone grafts aim to restore the endosteal and medium column. The current evidence shows equally high unit rates for both autograft and allograft, with no proven superiority from one over the other. But the autografts offer biologic advantage, but you have to consider the donor side morbidity, whereas the allografts provide comparable outcomes with fewer complications. The first choice is the fibula strut autograft. Among the bone graft options, this is the mechanical benchmark, and it acts as a rigid endosteal column. It's best suited for young or high energy fractures with true middle column loss, but the downside is that it's difficult to remove later if arthroplasty becomes necessary. The femoral head allograft, or the so-called French fry technique, this is the thin strips from the femoral head, which is a cancellous bone. It provides metaphyseal fill and internal buttressing, but remains RSA friendly, and it is ideal for osteoporotic voids. Iliac crest autograft offers a structural support and biologic activity and may be used for revision cases where biological stimulation may be required. And this is another option, the distal clavicle autograft. It offers similar biological and structural support with the addition of ease of surgery because you can just extend upwards. And but the downside is that you can only take a small amount of graft. And in severe osteoporotic cases, vascularized grafts may be an option as well. One is the pectoralis major pedicle bone graft. This offers the structural and biologic support and provides like a living cortical buttress beneath the calca. It has been shown to reduce loss of reduction and also improve function compared to the standard allograft, but it remains technically demanding and may be preserved for complex fractures with poor vascularity. And there are no many RCTs which compare this to other types of grafts as of now. Another option is the vascularized fibula autografts, but it's mostly employed in complex non-union settings, and there are still limited evidence in acute fractures of the proximal humerus. So when to use what? The principle is allograft is like a default mode, so it remains the option for most primary cases. So because it offers equal union and function to autografts with fewer complications, autograft you may be used reserved for situations where biologic or vascular enhancement outweighs the donor side risk. And vascularized autografts can be considered when there is compromised perfusion or non-union involved. For novel techniques such as cages and scaffold systems, this represent newer approaches to the internal column reconstruction. These devices restore the metaphyseal height and can distribute the load evenly and allow early mobilization. But current evidence, it's only from small case series and early multi-center cohort studies, but the outcomes are promising in both the radiographic and the functional side. However, there are no randomized comparative trials that demonstrate its superiority over standard plating or other bone augmentation options. For bone substitutes, the first one is the PMMA cement. This augmentation provides mechanical reinforcement. It fills the trabecular voids and strengthens the screw fixation. Targeted screw tip augmentation, this reduces failure rates and without increasing the risk of avascular necrosis from current literature. And the thermal risk is quite minimal with it being below the threshold for the osteocyte death. However, the cement is bioinert without any osteoconductive properties. So which screws should we augment? This is equally important because the inferomedial and posteromedial screws, which are the ones supporting the calcar, are the priority because they bear the compressive load and dictate the varus resistance. So it's not to augment all the screws, but the ones that are most important. Another option is calcium phosphate cement. This is an isothermal osteoconductive material, which hardens into a phase that resembles bone mineral. It has a closer mechanical match to cancellous bone compared to the PMMA. This reduces risk of stress shielding. However, the resorption is quite unpredictable, occurring from 6 months to 10 years. Another one is calcium sulfate. This resolves faster and it offers a biologic environment for bone formation, but has limited structural strength. So it may be suited for metaphyseal voids with preserved middle cortex and when biological integration is the main concern. This is another emergent evidence. It's a magnesium-based bone fillers. They combine the mechanical stability with osteogenic and also have angiogenic properties as well. Early studies demonstrate complete union and preservation of the alignment, but we still need the larger trials to validate the long-term outcomes. So hybrid constructs, because there's no single method that does everything. This combines mechanical and biologic augmentation. So the concept recognizes that there's no single fixation that adequately addresses everything. And the goal is to restore the column strength while preserving the vascularity. This is a supplementary role of the biologic modulation. There may benefit tuberosity healing or in revision cases with poor biology, but this should never replace stable fixation and should be reserved only for patients with compromised tuberosity biology, poor bone quality, or in revision cases. So to summarize, the decision framework for augmentation is best guided by the failure pattern rather than the fracture type. Arthroplasty becomes an option if the comminution is very severe, so neither the column can be restored or if the vascularity is doubtful. So to summarize, augmentation is about matching the solution to the failure mode. You have to rebuild the columns, fill the voids, secure the cuff, and preserve the option for future procedures. So only augment what is missing and do it with intent. Yeah, thank you.
Thank you. Thank you for your concise and excellent presentation. Any question from an audience? Please.
According to your presentation, if you found the case like 4 part in the elderly with severe bone void, which type of augmentation will you choose?
So you have to look at the fracture as the fracture configuration as well as also the integrity of the bone. So if it's very severe osteoporotic bone, you would want the structural support, but also be aware of you want the, I think for me, I would like to use hybrid constructs. So maybe also addition of bone allografts and also maybe plating as well. So a hybrid construct would be my choice.
I have a question. So in case of medial comminution, so how do you decide to augment the medial side of the proximal humerus? How you choose the option?
So I think
You in case of medial comminution, medial calcar disruption, you routinely support or the medial side, or you how do you decide? I mean severity of comminution,
yes.
or routinely augment.
I think for me, I would look at the severity of the comminution and to see whether you can restore the stability of the medial column just by the plating alone. But if it's if you can, I would think augmentation, you can also just add it with the medial plating with the as well. So I think if it's not too hard to augment, it's not you can also add the bone substitute and bone graft.
So actually, so plating on or to the medial side or the proximal humerus, maybe not the solution. And also, if you want to support the medial side by structural graft, it is not easy to perform as well.
Yeah.
So I personally, I augment, but only in the revision surgery. But in the acute cases, I don't. So and also that is the question. That's why I asked you, how do you decide to augment?
Can I have a question? First of all, you did very good presentation. I just wonder, nailing is the nailing is the option as the augmentation, because nail can fill the void, right? And biomechanically it's better than the plate. And is there any techniques to augmentation with the intramedullary nailing for proximal humeral fractures?
For my literature review for the nailing, I haven't seen it as talked about as kind of like an augmentation choice, but more of a fixation choice. So maybe I would need to go back and review a little bit more about this.
We'll also welcome the question from the online. I'm not sure the online the faculties in the Zoom application, they can talk with us.
One question. So you tell us a lot about the advantage of all the options. Are there any data about disadvantages or complication comparing between like so many solutions that you provide to us?
So obviously for the autografts, the disadvantage is the donor site morbidity. So it's different for each one. So it depends on what you use to where the autograph comes from. And for the allografts, it only has it's only structural support, so there's no osteogenic or osteo integration involved. And for the other solutions, like this PMMA cement, it's only the structural support as well, so there's also no biologic behavior, and also the cost. Yeah.
Thank you. Thank you for your excellent presentation. Okay, we'll move to the next topic, which is one of the very rare injury, right? With peri-implant fractures of the humerus, how to treat, from Dr. Kittipop Sitti from Shanya University Hospital. Advisor is Dr. Pauwel from Shanya University Hospital. Please.
Good morning, all audience. My name is Kittipop Sitti from Chiang Mai University Hospital. I will present a review the topic of the trauma corrective review and peri-implant fracture of the humerus, how to treat it. My advisor and assist Professor Pauwel Nimkingrat. Before we dive into the treatment, let's clarify what are discussing about what the implant of peri-implant fracture of the humerus. The humerus fracture is occur about 4 to 6% of the all fracture. The incidence is increased with age and common in the proximal humeral part. Surgical fixation is a standard option, and the treatment for the list of the complication is non-union is the most common. Infection and also implant fracture is the rare complication. For the peri-implant fracture, humerus is one of that occur previous place on the implant and also have the plate and screw and also IM nail. But it's totally different with the peri-prosthetic fracture. It's occur around the joint replacement component. It's totally different entity. So today we focus on the non-prosthetic peri-implant fracture. Why do this fracture is occur? This also means is the biomechanic failure. The implant create the stabilizer on the stabilizer wrist area and also fracture at the end of the fixation, and caused by the elastic motility mismatch between the stiff implant and surrounding bone. This study shows where the state concentration in the nail implant, the red circle area indicates in the high state in the end of the distal lock on intermediate nailing in humerus. Another example for study focused on the plating on humerus is occur about the age of the implant on the bone interfere between it. And how often of it? Although rare is look at the number of the data is small case series. The first is case data series from USA for the 61 peri-implant fractures. Only 7 is on the humerus and all cases were plate and screw fixation. Another case series from Romania for 5 years ago is on the 85 peri-implant fracture. Most cases are the femur and only 7 cases are humerus. According to the 2 case series, it showed typical on the older age and often on the female. For the current 10 cervical intervention humerus fracture is on the OIF or IM nail is increasing in US database. Is rise of imply of an uptrend of the peri-implant fracture also. What is the risk factor of humerus peri-implant fracture? The risk factor is to categorize in the bone and patients and also implant and surgical factor. The bone and patient is at one age, female osteoporosis, disuse osteopenia and also comorbidities. Surgical implant is non-union large bone defect, varus malreduction, and also elastic modulus mismatch. Any classification is for the humerus peri-implant fracture. In the peri-implant fracture is a lack of comprehensive specific classification for it. But the current system is described but not the guide of the treatment. Already have a tool of the classification on it. Let's focus on the one ago on the 2029. Its period implant fracture classified by the plate and IM nail. It described based on location and relative to the implant. For the next is novel comprehensive classification from the recently on last 2 years. As a newer comprehensive classification led coded on the system based on the AO number, a type of implant, and also hardware and fracture location. This is the example of the summary. And how to approach a humerus implant fracture. The assessment is the systematic assessment for the vital planning for and treatment, patient status, implant status, fracture pattern. For the patient status, age, medical comorbid, osteoporosis, neurovascular status must be assessed. For the implant status, sign of infection is crucial. Type of implant, loosening, stability, and broken. It also have the old fracture is healed or not, or non-union or failure. And we need to describe the new fractures, location, extension of it, degree of comminution, displacement, and bone stock. For the diagnostic imaging, the serial radiography compared with previous is important to check the stability of the fracture and also the implant previously. For the role of the CT scan is often needs for the more complex case to assess the extension for the location of the implant, for the stability and assessment of the fracture is healing or not. Next, for the how to treat the peri-implant fracture of the humerus, what are the choices? First, non-operative treatment is very narrow role as a controversial indication. Its only indication is the high-risk patient, non-displaced fracture, proximal well-fit and stable implant, but it's highly to failure and rate of non-operative and be converted to the operative as very high risk. For the operative treatment, the treatment goal is to restore anatomical alignment, achieve rigid and stable fixation, maintain the bone stock. But key for successful is to rule out the infection first. The construct must be length, adequate, and rigidity. Preserve the soft tissue and also vascularity. Also, a workup is important after fixation. This is a show the option of the operative treatment in the two ways. One is the remove and another one is the retain based on the old implant. The key decision is what is the when to retain or remove the previous implant. The first, when the retain implant, if the original plate or nail and is stable, anatomical aligned, not broken, its strategy is to add supplement and augmentation of plate and with minimize soft tissue disruption. The operative that have depend on the previous implant plate or nail. If it's on nail, it can using the bridging plate or the augmentation. But if it's on the plate, overlapping bridging plate, stack plate, and KY external fix can be used. The first one is example of the bridging plate augmentation after the previous nail implant is broken on the distal of humerus. The clinical outcome is look good and union on the 100 about days, and the functional outcome is good too. And also when previous is the plate, but we need to replace the placement. Another option is the stack plate. In this case, theory is called the stack plate. Using the phylloid plate in previously with a fibula stat gap, and also have the distal fracture, we add another small LCP for stack plate. And another complication, no complication, full RM and position is look good after following. And also phylloid, double phylloid can use all the stack plate, and also have some of case series from the Chinese. 3 month follow-up is called critical union, no pain, able to daily activity without pain also. For the overlapping of the plate after retaining of the implant, have the field retrospective of the clinical study. It's called in only 6 cases or union without complication and good functional outcome. They have only of the 2 cases from the Indian journal is also called the KY with external fixator and have another of the good clinical outcome, but end only two. What about the remove implant? The remove implant is important when it is loose, broken, or poorly positioned, and revision is fixation is more longer, man needs to rigid and bridging entire of compromise and stage shooting zone. But we need to minimize the soft tissue disruption. The two options is based on previous implant to remove it can use a helical plate or bridging plate or revision longer nail. But if the previous is the plate, the helical plate or bridging plate, it can be also. This is the example of the revision of the longer nail and good functional outcome, but in only one case. And another case is the remove for the non-union and failure of the implant. We can convert to a bridging plate and good functional outcome at the 6 months too. For the helical plate, we can be used also for limitation is we need to prevent the plate before the using, but the 2 case report is 1 year follow-up is very good of the experience. Another is when they combine with the complex fracture on the humerus, we have the 1 case report. We use remove the previous nail and use the helical plate with distal locking plate. It's also good in the functional outcome and union in the 6 months without aim is look good. For the author prefer algorithm for the humerus peri-implant fracture, when we found with the humerus peri-implant fracture, we need to see the contraindication for operative or not. Just like the medical convenability, this plate just minimal, well-fixed, stable implant, we can use non-operative treatment. Or if not, operative treatment is the one of the option, but we need to get rid or rule out the infection first. If the infection is unconfirmed, environment and culture, if the stable implant, we can retain implant or remove it and stabilize for get rid of infection. But if not, the period implant is here is remove and retain implant, and also the have the if not heal remove implant is okay. This is a summarize of the treatment plan and option based on the implant that period we talk about it. And what next is the key concern for the next humerus peri-implant fracture. The managing is on the peri-implant is a high biologic and medical risk due to complex revision environment. Is very high complication rate and reoperation rate. The specific critical complication is non-union, secondary nerve, implant failure, and infection. The conclusion, humerus peri-implant fracture is complex and trauma challenging to management. Its uptake increase due to fixation is very common in nowadays. But lack is the comprehensive humerus peri-implant specific classification for it. Evidence just only small case series and rare due to underreporting, a small room in the non-operative management. And key to success for surgical management is one is rule out infection first. Construct must be adequate length, rigidity, and preserve soft tissue and environment. Mandatory is osteoporosis workup and treatment following the fixation. Thank you for my attention. Thank you.
Thank you. So this is one of the difficult topic because still lack of the evidence. Okay, at least Dr. Kitty also able to summarize us some case series that he found in the literatures. Is there any question from the faculties? Please.
Okay, so thank you for the presentation. It's simple, and I think I get something out of your presentation. Thank you. So I'd like to ask information about the stack plate. All right, so in case that you're going to use this way, how many holes that you need to overlaps between the old and new plate, and what kind of plate that you recommend us to use?
Yeah, in my opinion, from my review, it's just already the four cases is on the stack plate. The first one is on the LCP. Overlap is only two locking screw between the previous plate and the new one. But I very recommend is if we have to go this way, the locking plate is very recommend because of the locking mechanism of the plate over and the previous is very important to the stack plate is one. But if you use conventional, it's not any of the enough stability for fixation on the stack plate. Yeah.
Thank you for your presentation. You mentioned about the fractures of the tip around the tip of the intermedullary nail is most likely of the stress slicer effect, right? Is there any recommendations about the designs of the nails and the screw placement, and also where it's appropriate to place the end or the tip of the nail to prevent or minimize the stress slicer?
Thank you for the question. It's very interesting question. This I reference from this paper. This paper is talk about the safe distance between the locking of the distance of the nail, and the end of the nail is should be upper of the orecranon of the fossa, because of the end of orecranon fossa when you see on the bone is very narrowing in the upper the orecranon fossa. If you should put more deeper and more distally, is merely put in the deep and narrowing canal, and the tip of the nail and also the screw is very straight on over that. But if when the fracture is over on the proximal shaft or let's see, proximal shaft or on the shaft, you can just only the bridging on the enough length. You can stop at around the or over more, not to the distal. But the number is not quite have the recommendation on this paper. But if it's very distal, it's more sterilizer, it's very good. Yeah.
The case, sorry, thank you. Thank you for your presentation. Very good. So in the case that you have peri-implant fracture after you do nailing, and you need to remove the nail, I think it's not easy because every time you insert the nail from humerus, you need to sink it down, right? In order to prevent the irritation to the rotator cuff. So how you have any solution that you can remove the nail if you would like to do?
Yeah, in my opinion, if they have the peri-implant fracture on the distal part, just like the image on the third page, you can put mini open on this one, because you need to bridging the page on this one, or the reverse or the nail. You can mini open and remove it by the fracture side. I think it's very good for the solution. Yeah, but if you want to remove from the upper, I think it's not quite. It's very difficult. Yeah, I have one for it.
The nail from the fracture side?
Not really for the retrograde it. Yeah, remove all the distal lock and proximal lock and put the retrograde it remove from the upper. Yeah, but mini open of this one, I think is very good, because you need to, if you choose the bridging page or page over the previous nail, I think you need to open the fracture side, of course. So when you get off the screw or screw, you can put the nail upper for retrograde just like that. Because when when we in nailing of the humerus, the tip is very sink down.
Yes.
And don't have any callus over that.
May I ask one question about the stack plate? If we can do both, whether we remove the plate before we do another plate, or we can, then which one would you love to do? Whether we use the stack plate or remove the implant and put another plate on?
It's about my opinion. Yes.
You have to take consideration before you go in, because you have to compare which one is better.
In my opinion, if the patient and the fracture is very the distal part and the previous implant is very stable, and some kind of the comorbid, is you have to very minimize all the blood loss. So the stack plate is very good option. Just only remove some screw and got the plate bridging is very good. But if everything is fit, the revision is very better.
Thank you. So, okay, thank you, Dr. Sitti. Okay, so we'll move to the next topic. We will skip a bit to the infection part. I would like to invite Dr. Chatupon Soviraj from Nakhon Ping Hospital. He will talk about the infections after osteosynthesis, implant retention or removal. Advisor is Dr. Thanawat from Nakhon Ping Hospital.
Good morning, everyone. My name is oh, my- กดได้ครับ
เดี๋ยวเพื่อความต่อเนื่องนะครับ เดี๋ยวพอน้องเขาเริ่มดิสคัสครับน้องคนต่อไปก็เอาสไลด์มาขึ้นเลยเนาะเพราะว่าแต่ละคนก็ไฟล์พิสดารเนาะจะได้ใช้เวลาในการเอาไฟล์ขึ้นให้เต็มที่นะครับ
ร่างไม่ขึ้นครับอาจารย์น้องใช่ครับครับเอาไป
section ครับเป็นหัวข้อมีเวลาและข้อต่อบ่ายโมง34ครับ
เรียบร้อยแล้วอันล่างนั่นคือล่างนั่นคือจอยแล้วเวลากดหน้านี้ที่สเปซไซด์ครับคือการเขียนได้เลยครับที่ผมดีได้Good morning everyone ครับ My name is Chatupon Soviraj from Nakhon Ping Hospital เชียงใหม่today my pleasure to present to the topic infection after osteosynthesis, implant irritation or removal. Advisor Dr. Thanawat Valaipatchara Osteosynthesis associated infection or OAI. Definition infection occurring after surgical fixation of fracture with internal paste implants. Most common is open fracture. This is infection according to the Casiro and Anderson classification. In the grade 3, in the 4 to 52%. In the code factor is 1 to 2%. Goal of the treatment. First, eradicated infection. 2, allow factor healing. 3, preserve body function. 4, prevent its recurrence. Risk factor is two groups. One first is the patient factor. Smoking, diabetic mellitus, immunocompromised elderly. Another factor is controllable prophylactics, antibiotics, delayed debridement is more than 6 hours. Reaming, prolonged death, or the prolongation of surgery. Most common is pathogen is Staph aureus. In the hospital, nosocomial infection is Pseudomonas aeruginosa and Acinetobacter baumannii. This where is the pathogen have been the biofilms. It is resistant to the host defense. Is a macrophage for phagocytosis. Is a biofilm formation. Now in bacteria inoculation bone and implant is 1 to 2 weeks. Biofilm as is the surface of implant area. Biofilm have the two groups of factor. First is the surface factor, such as surface topology charge. In the environment factor is the temperature, pH, electrolyte concentration. In the implants material is the first stainless steel most infected is the Staph aureus infection. In the titanium alloy have most to the biofilms. In the plate, low contact paste infected rate less less than the conventional plate. In the nails, cannulated open section nail more infection. In the infection and the fracture stability, infections persist more than 2 weeks, induced to the excessive bone resorption turnover, have the lead to the mechanical failure, instability, or the non-union. โทษครับรูปรูปนี้ขึ้นอันนี้ออกครับ in the picture is the pathogenesis of OAIs. In the all interface คือ 2 weeks. Diagnosis, clinical first, local pains, erythema, swelling, purulent discharge, sinus formation. In the image study is pain film seen intensive periosteal reactions, implant loosening, non-union. In the CT, in the scene sequestration, in the status of fracture healing. Ultrasound is more than corrections of the infections. In the PET is increased glucose metabolism. It induces increased infection in case. Blood test is a sensor leukocyte count, ESR, CRP, and the fluid or pus have to use swab and culture for the pathogen, and antibiotics susceptibility test for the specific pathogens. Classification is the many classification, such as is the time after surgery, acute delay rate. Second, root of the infection, direct hematogenous. Fracture healing is a severity callous for the in the case. Clinical severity is a superficial or deep. In the last host type is the type ABC. Type ABC have the factor group is the systemic group and local group. Type A, no significant factor. Type B, 1 or 2 factor. Type C is a 3 or more factor. Is a classification is. Factor stability and implant retention maintain the factors stability successful 56 to the 86%. Now fracture union may just the implant removal. Potential dead space is smaller. Inward joint lie the living cartilage is good. In the treatment, in the 3-phase in the treatment in the acute 2 weeks after osteosynthesis, delayed phase 3 to 10 weeks after osteosynthesis. Is the last phase late is more than 10 weeks after osteosynthesis. In the last phase is the fracture union have be late infection. In the treatment, it's a 5 type phase treatment. In the picture show is the first non-operative amniotic use cephalosporin 2 weeks because staph aureus improved. No surgery. In the second device, is the implant retention have vancomycin more than 6 weeks. In the first 2 weeks, use intravenous antibiotic vanco. In the surgery, have the device implant retention have be bone defect due to the two-stage procedure. In the T-type convention of fixation have the vancomycin 6 weeks and the IV 2 weeks. Operation device implant removal and the external fixator inward joining and the bone defect have the two stages. Implants removal use cephalosporin 2 weeks and the device implant removal. Last, the suppression therapy means patient can go to surgery. Use the cephalosporin 2 weeks and no surgery. Fixation have used the external fixator unit, HANA ring, or the external fixator used to LCP. And the two-stage approach is antibiotic cement spacer and second stage in bone graft. In the picture show antibiotic and bone graft two phase. In the hand film X-ray show to a union. In the case at tibia is 20 months. In the future, have massive bone defect happen. Massive bone defect is less 4 centimeter is used to set. Is the last bone defect used dissection osteosynthesis. Soft tissue defect less 2 centimeter primary closure. Severe tissue defect needs a fact. In the articular involvement, you have the osteoarthrodesis, prosthesis dependent. Sorry.
Any questions about the infection, please?
Okay. According to your presentation, which one is the most important factor that you decide to retain or remove implant?
The key factor is the fracture healing first. Can go to the implant retention in the first นะครับ
ได้ครับ
ครับ
ได้ครับ
ขอโทษครับ
โอเคครับเอาตอบไปเลยก็ได้ครับ
ตอบเลยกันนะครับ
ครับ
คืออย่างนี้ครับ คือเขาจะซักเจตว่าเรารีเทนไว้ก่อน ในครั้งแรกที่เราเจอเคสปุ๊บพยายามรีเทนอิมแพนอันนี้ไว้ก่อนแอนตี้ฟิกอัดไว้ก่อนไฮโดสไว้ก่อน แล้วก็จับเชื้อให้ได้ ซึ่งเขาบอกว่าโมดคอมมอนของเชื้อเนี่ยส่วนใหญ่เป็นแซออเรียสมักจะยื้อได้ พยายามยื้อที่ไหนให้สุด ส่วนไทป์ของการยื้อที่ผมพรีเซนต์5สเตจในการรักษาครับจะเป็นหน้านี้ครับ
ครับไม่เป็นไรเอาแค่
ครับ
คำต
ป
อบ
ระมาณ
ก็พอ
นี้ครับ
ครับ
หน้านี้เป็นตัวหลัก ก็จะเป็น5กลุ่มของคนไข้ที่มา ยังไงก็เขาบอกว่าให้ยังไงเมนเทนอิมแพนไว้ก่อนแล้วก็ฉีดแอนติบิโอติกไป ถ้ามีปัญหาเรื่องโบนดีเฟกก็เซคันด์สเตจถ้าเริ่มดื้อยาเปลี่ยนยาจะมีอีกหน้าที่เป็นโคพอดีเมื่อกี้ไม่ทันก็เปลี่ยนยาตามเซนส์ของ ตัวเชื้อครับก็คือเน้นไปทางนี้ก่อนมีกรณีเดียวที่รีมูฟคือไม่ไหวแล้วอิมแพนมันคอนโทรลอินเฟคชันไม่ได้ตัวอิมแพนมันลูสนิ่งเนี่ยครับเพราะฉะนั้นนำที่รีมูฟทันแล้วก็ทุกเคสเนี่ยมันสามารถรักษาจบปุ๊บแฟกเตอร์ยูเนียนเรียบร้อยให้ออฟตัวอิมแพนทุกครั้งในทุกเคสที่เขาเทสครับ
ครับเรียนเชิญอาจารย์บรรจงครับ
ขอบคุณสำหรับ ข้อมูลนะครับอยากทราบว่าที่รีวิวมาเนี่ย
ครับ
มีการให้ข้อมูลอะไรต่างๆในการเปรียบเทียบระหว่างการใช้ stainless steel กับ titanium material อันนั้นประเด็นที่หนึ่ง
ครับ
material ที่เราใช้เนี่ย
ครับ
อะไรที่มันมีโอกาสที่จะเกิดปัญหามากกว่า
ครับ
ประเด็นที่สองก็คือคุณพูดถึงเรื่อง intramedullary nail ในลักษณะที่เป็น cannulated
ครับ
มีโอกาส infect มากกว่ากรณีที่เป็น solid
ครับ
ถูกต้องไหมครับ
ถูกครับ
อันนี้ในกรณีที่เป็น cannulated เนี่ยมันจะมีลักษณะ open section กับ cross section
ครับเขาแนะนำ
มี
ว่า
คนพูดไหม
มีคนพูดครับ
ใช่
พอดีเนลมันจะพูดค่อนข้างน้อยกว่า แต่คือเขาสังเกตว่าถ้าเป็นโอเพนเนลเนี่ยมีโอกาสอินเฟคชันมากกว่าโคสแล้วก็การรักษาของตัวเนลเนี่ยไม่ต่างกับเพจเลยใช้วิธีเดียวกันก็คือยื้อเหมือนกัน พยายามยื้อคือรีเทนตัวเนลไว้ก่อนฉีดแอนติฟิกก่อน ยกเว้นว่ามันเข้าอินดิเคชันว่าอินเฟคชันคอนโทรลไม่ได้แล้วก็ลูสนิ่งแล้วถึงจะออกเนลครับอาจารย์
titanium กับ stainless steel
ไทเทเนียมสเตนเลสสตีลคือเปอร์เซ็นต์มันไม่มีชัดแต่ว่าเปเปอร์อินดิวส่วนใหญ่ว่าในสเตนเลสสตีลเนี่ยมักจะคอนโทรลไอตัวอิมแพนได้ ก็คือยื้อไปรีเทนไปแอนติฟิกไปมันแค่เจอเชื้อแซดเป็นส่วนใหญ่
เชิญครับอาจารย์
นอกเหนือจาก material ที่เราใช้แล้วเนี่ย มันจะมีประเด็นเรื่อง surface treatment ด้วยนะ
surface treatment
นะครับ
อ่า
มีลักษณะของการโค้ดหรือว่ามีลักษณะ smooth surface อะไรต่างๆของ implant นี่มันมีผลอยู่ เขาก็เมนชั่นยังไงบ้าง
เป็นช่างไงบ้างคือกลุ่ม stainless steel เนี่ยเป็นกลุ่มที่เป็นโลหะที่เป็นเคลือบมาครับ เพราะฉะนั้นไอตัวเคลือบเนี่ยมันไบโอฟิล์มมันเกาะยาก แต่ถ้ากลับกันไทเทเนียมอลลอยเนี่ยมันเป็นตัวชุบมาของโลหะครับไบโอฟิล์มมันเกาะง่ายกว่าแล้วเจอเชื้อดื้อยาของไบโอฟิล์มที่รักษาคอนโทรลยากกว่าเคสพวกเนี้ยมันต้องค่อนไปทางยื้อยากแล้วก็ต้องรีมูฟตัวอิมแพนครับ
ขอบคุณครับ ขอคำสั่งสุดท้ายครับเชิ
ครับ
ญครับ
ขออนุญาตผมเป็นไม่ถามแล้วกันนะครับแต่ผมขออนุญาตแนะนำคือประสบการณ์ผมเนี่ยคือเคสไอ้พวกinfection พวกนี้ผมเจอทุกวันเนี่ยมันมีปัจจัยหนึ่งที่บางคนอาจจะไม่พูดถึงอันนึงคือโบนที่มันหักอะคือสำหรับที่เบียร์นะในประสบการณ์ผมไม่เคยเก็บไว้ได้อินเฟกไม่ติดนะฮะผมแนะนำว่าถ้าเป็นที่เบียร์นะเราควรจะมีเทสโชต่ำๆที่จะ
คือรีมูฟง่ายขึ้นนะครับ
ใช่
เพราะ
แต่
ว่า
ว่าถ้าเป็นฟีเมอร์เป็นฮิวเมอรัสอย่างเงี้ยผมว่ามันมีโอกาสอาจจะเพราะว่าคงเรื่องบัตรซัพพลายอะไรต่างๆ
ใช่ครับเขาบอกว่าดีเฟกติ้งเยอะวัดสปายมันแย่มันก็จะยื้อไม่ได้ครับต้องรีมูฟครับ
โอเคครับ
Thank you
Thank you. Okay, so we'll move to the last topic from the previous from the first section. This is the topics about the treatment option in Pauwel type 3 femoral neck fractures from Dr. Kakanan GMD from Pauwel Hospital. Advisor is Dr. Rahat Jarayapan. Please.
Good morning, everyone. My name is Kakanan Chiamdee. I'm from Pauwel Hospital. Today, I would like to present my topic talking about treatment option in Pauwel type 3 femoral neck fracture. Okay, let's start with the definition. The Pauwel type 3 is defined as a vertical fracture line of femoral neck with more than 50 degree angle as a picture you can see on the right side. It has the specific characteristic with high shearing and varus force. So it can lead to a high risk of post-surgical instability and complication. So the important thing that we need to get an anatomical reduction and provide a high stability fixation to deal with this type. Okay, this is the summary table of the treatment recommendation. Now we can divide in many groups. The first group is a non-fixed angle device. Second is fixed angle device and augmentation. And there are new literature talking about the novel fixation device. And there are some role of the primary osteotomy with fixation. And the last is the arthroplasty. It's scary that we would like to preserve the femoral head in the young patient. So in this topic, I will focus focusing on fixation option. Okay, let's start with the cannulated screw. This is the technique of fixation that has been long used, but nowadays there are many literature reviews suggest that this technique may be not appropriate in the patient with Pauwel type 3 femoral neck fracture because it is high fixation failure and reoperation rate comparing to the other fixed ankle device. So we recommend not using this device as a solely treatment in the Pauwel type 3 femoral neck fracture. Later, there is a new fixation method using traditional multiple cannulated screw, but combined with a new modified screw direction technique. It was oriented perpendicular to the fracture line. Many studies found that the modified screw direction to perpendicular fracture line give more anti-shearing and rotation property than the traditional screw. It also gives more interfragmentary compression to fracture site than the traditional screw. As you can see, the picture on the left side, the additional screw can give the more stability, and the right side, it also, if you modify the direction of screw to perpendicular to fracture line, it can provide the most stability when comparing to the other group. The next is pressing the screw to achieve a larger cross-sectional area. It can also improve the mechanical stability. From this study, they call the oblique triangle configuration. It shows superior mechanical property than the traditional invert equilateral triangle configuration in the finite element analysis. This study suggests that when the three screw is used in the traditional method, the larger cross-sectional area of screw configuration can provide a better stability than the traditional method. Next is another technique is changing the number of screw fixation from 3 to 4 screw. There are the biomechanics study that using 3D printing saw bone from healthy volunteer, and then they create a Pauwel type 3 70-degree femoral neck fracture, and then they evaluate the configuration of internal fixation. From this study, they found that the alpha type in the top of the left corner, they found it provide the best stability when comparing to other group. The other technique is changing to screw from the partial thread to headless fully thread screw. It's called the compression buttress screw fixation method. They do the biomechanics study, and they compare with the traditional method with medial buttress plate augmentation. In this study, they has the potential advantage in the biomechanics, and it has an advantage in the minimally invasive when compared with the medial buttress plate, but there is still a lack of clinical evidence. The next method is a modified trajectory screw direction technique. It was produced by Dr. Kittipop. It's called biplane double supported screw fixation, or BDSF. He explained that this technique offers a better osteosynthesis stability by having two screws to buttress at medial cortex to inferior cortex of femoral neck as a gray and blue color screw in the picture on the left side. And then his third screw is inserted from the distal side, passing inferior cortex of femoral neck and buttress to the posterior cortex of femoral neck as a red color screw in the picture. In his third screw, he usually put in 150 to 165 degree on the coronal plane as an obtuse angle. This is in this paper, he explained his surgical technique step. In the picture on the right side, he start with the placement of middle guide wire first as a blue color screw. Then he do a superior guide wire and finish with inferior guide wire. He also had the clinical study of his technique, and he found that the BDSF technique provide a higher rate of bone union and lower rate of fixation failure than the traditional screw. but from his study, it's not clearly mentioned about how much case is the true Pauwel type 3. There are comparative study in each school technique. The first study, they compare about traditional screw with BDSF and modified BDSF and dynamic hip with anti-rotational screw. They found that the modified BDSF show the superior outcome than the other techniques. And second study, they compare the traditional screw with BDSF and four cannulated screw with off-axis screw. They found that in this study, four cannulated screw with off-axis screw provide the best stability. And the last study, they also compare the traditional screw with BDSF and four cannulated screw, and they found BDSF 165 degree show the best performance. So it's still a controversy. Next, we are moving to a fixed angle device. First, we are focusing in dynamic hip screw. This is a device which consists of a lag screw with side plate. It allows sliding effect of lag screw to create an interfragmentary compression at the fracture site. It was developed for unstable femoral neck fracture, but in Pauwel type 3, it still has a non-union and AVN. There are an evidence from study that optimal fixation in Pauwel type 3 femoral neck fracture is dynamic hip screw augmented with anti-rotational screw. So we are recommend using the dynamic hip screw in combination with anti-rotational screw. Okay. Later, there are some of modified technique to improve the good result from using dynamic hip screw in the Pauwel type 3 femoral neck fracture. In the first study, they adapt a traditional anti-rotation screw to use a fibula bone graft, replacing the old method. From his comparative study, he found that his new technique promote faster bone union and reduce an AVN rate. And second study, they found that the positive buttress reduction is an effective treatment in femoral neck fracture Pauwel type 3. So it is an alternative option if we can achieve anatomical reduction. Another technique involves adding an anti-rotational screw, increasing the number from 1 to 2 screws. From his biomechanics study, he found that 2 anti-rotational screw and medial buttress plate augmentation group can effectively reduce the movement of fracture site and shearing force to the dynamic hip screw. Next, we will talk about a new device that has been increasingly used in a recent year. Is it a femoral neck fracture or femoral neck system or FNS? It was developed by AO Foundation. So the main developers are Dr. Karl Stoffel and Christoph Sommer. It is a fixed angle gliding fixation device that have a bowl with anti-rotational screw inside a small barrel plate. It has a mechanical property of decreased rotational force at head neck fragment and allow the control collapse, which provide anti-shearing and varus force. It has an advantage in the more minimally invasive property. This is the first biomechanics study of FNS. They compare the biomechanic property with dynamic hip screw, dynamic hip blade, and the traditional cannulated screw. From his study, they found that FNS is a valid option to treat an unstable femoral neck fracture. It also has an advantage of minimally invasive implant and its comparable stability to dynamic hip screw and dynamic hip blade, and it's superior to traditional cannulated screw. There are a comparative study of FNS with other technique. Mostly it better than 3 cannulated screw, but in some study they found that 4 cannulated screw is better. And some study they found that FNS is similar to dynamic hip screw, and surely that they better than traditional cannulated screw. And there are a study that focusing about effect of NS bolt position. They found that if we place a bolt to superior in AP view and to posterior in lateral view, it will have a chance of fixation failure. And this is another study, the effect of implant. It said like that in the lateral view, if you place a ball a little bit anterior, it better than posterior. Okay, next we will talk about the medial butt test plate. It is the augmentation technique. There are many comparative studies between the medial butt test plate augmentation with the other technique. In the medial butt test plate augmentation group, they found that it significantly decreased an angular displacement and shear displacement when comparing to the rotational screw group. And this study is clearly conclude that augmentation of medial butt test plate in traditional screw can provide better stability than traditional screw alone or medial butt test plate alone. And there is a systematic review that medial butt test plates are valuable adjunct managing in Pauwel type 2 and 3 femoral neck fracture, which provide the favorable outcome with low rate of failure and complication. Okay. Next, I will talk shortly about the new implant in the Pauwel type 3 femoral neck fracture. First, left side, it called the Talon cannulated screw compression device. It adapts from the traditional screw by having a claw at distal thread. It gives a better stability than a conventional cannulated screw. And second is the locking cell compression screw, or it called X-pin. And the third, it is the slide compression anatomical plate of femoral neck. So, but nowadays, all of these implants, they are still have only the biomechanical study. It lacks of the clinical study. And the other method is do the
I
primary.
think it's time for question. Okay.
Okay.
Thank you.
Thank you so much. So I have 3 questions to you. So if you have young patient with the Pauwel 3 fracture, neck fractures, what is the best implant that you will select for your patient? Second question, you know that the FNS have 1 hole and 2 holes, right? How do you select 1 hole and 2 holes? And the third question, is there any difference? Is there any evidence that showing FNS with medial plate augmentation from your review?
Okay, for the first question, in the young patient with Pauwel type 3, I recommend the fixed angle device. From my review,
you use the fixed angle device alone or with other implant?
I will prefer to use the dynamic hip screw augmented with anti-rotational screw first, because nowadays the literature review of the FNS in Pauwel type 3, there is still lack of the evidence that it could resolve.
Okay, it's one evidence from JOT last year. It's a big series of almost 600 patients, Pauwel 2 and 3. If you have just used single fixed angle device alone, the failure rate is about 46%. However, if you use the fixed angle device plus medial plate, the failure rate dropped down to 11%. So nowadays, I personally recommend you to use fixed angle device plus medial plate if it's possible. Okay. Second question.
Again, please.
Post evidence how to select.
1 hole or 2 hole. Okay. From my literature review, it have the evidence of failure in FNS with 1 hole. So if it Pauwel type 3 more than 70 degrees, I recommend to use 2 hole.
Okay. So what about the evidence with medial plate? Is there any study about that?
As I review, I don't find any the literature review that talking about this, but there is only the literature review that suggests medial plate as an augmentation option. but there is no study that study about the medial plate combined.
There's no, right?
Yes, there is no.
Okay, thank you.
อาจารย์เชิญครับ
ขออนุญาตเป็นไทยนะเพราะจะได้เข้าใจตรงกัน ในกรณีที่เป็น biplane double screw ใช่ไหมครับที่คุณเมนชั่นเขาได้รีวิวเปเปอร์ก่อนหน้านี้ โดยเฉพาะอย่างยิ่งเปเปอร์ของการ์เด้นบ้างไหมมีการใช้เปเปอร์ของการ์เด้นหรือเปล่าเพราะว่าลักษณะของการใส่สกรูที่ตำแหน่งที่อยู่ตรงแถว subtrochanter นี่คือปัญหานะ
คือ
เขาพูดบ้างหรือเปล่า
เขาใช้เป็นการ์เด้นเลยเหรอครับแต่เขาไม่ได้พูดถึง Pauwel เลยครับจริงๆในเปเปอร์เขาอะครับ
ไม่รู้นะอันนี้มันเป็นเปเปอร์ที่เกิดขึ้นทีหลังแต่ในช่วงพีเรียดตั้งแต่ผมเทรนจนกระทั่งณเวลานี้เนี่ยเขาแอดโวเคทว่าไม่ควรใช้สกรูในเลเวลที่ต่ำจาก subtrochanter เพราะมันจะเกิด fracture ตรงตำแหน่งนั้นซึ่งอันเนี้ยคุณกำลังจะสร้างเหตุการณ์เดิมเกิดขึ้นจากไอ้ไบเพลนที่คุณพูดถึงโอเคนะให้ระมัดระวังอย่าไปฟังมาก
ขออนุญาตคำถามหนึ่งครับ
เชิญครับคำถาม
ข
สุ
อ
ดท้าย
เป็น
เชิญ
ภาษา
ครับ
ขอเป็นภาษาไทยแล้วกันนะค
เอา
รับ
เลยครับคำถามสุดท้ายครับขอบคุณครับ
น้องบอกว่าน้องรีวิว literature มาว่า mechanic testing ระหว่าง dynamic hip screw กับ FNS เนี่ย dynamic hip screw อ่ะมัน superior ใช่ไหม with single rotation ใช่ไหมครับ
ใน biomechanics ครับมันเจอว่า FNS เนี่ยมันเท่ากับ dynamic hip บวก single rotation screw
คำถามคือไอ้ biomechanic testing นั้นนะมัน test ใน manner ไหนมัน test ใน manner rotational stability หรือว่า manner ของ shearing compression
มันเป็น sharing ครับมันจะเป็น paper
มันเป็นแบบมันเป็นtradition mechanic testing เนาะงั้นก็แต่คือในปัจจุบันมันมีข้อมูลเพิ่มขึ้นเกี่ยวกับเรื่อง rotational stability เนาะยังไงก็อันนี้มันเป็นมันที่เคยเห็นนะมัน versatile คือไอ้ single screw อ่ะมันกัน rotation ได้น้อยกว่า triangular screw ในขณะที่ก็คือเนี่ยไอ้ dynamic hip บวก single anti rotational screw อ่ะมันจะกัน rotational ได้น้อยกว่า triple cannulated ในขณะที่ triple cannulated screw ก็กันเรื่องของ shearing force ได้น้อยกว่าดังนั้นเนี่ยFNS เนี่ยมันจะเป็น implant ตรงกลางที่มันกันได้ทั้งคู่แต่ว่าไม่ได้ max มันอาจจะอันนี้ให้ลองติดตามอันนี้มีข้อมูลใหม่เพิ่มขึ้นเกี่ยวกับ rotational stability ที่ก็เป็น point ให้อยากดูไว้หน่อยหนึ่งครับ
ขอบคุณครับก็ I think this is the last topic of the first section. We will have 15 minutes break and then we will come back at 10:15. Okay. Thank you. Thank you. Okay, I think we will begin the second sections of the collective review. And from most of the topic in the second part is the complex fracture in lower extremity and also the polytrauma management. And I just want you to remind you that, okay, the question is very common in all of this topic because we select the topic which is still have been debated and still lack of a conclusion yet. So that's why we want to review these new technique and also the evidence regarding to this issue. So we'll begin the first topic of the second section with the management of the ipsilateral femoral neck and intertrochanteric fractures by Dr. Chanakan from Siriraj Hospital. Advisor is Dr. Phonsak Niransu. Dr. Chanakan, please.
Thank you. Good morning. I am Dr. Chanakan Ungboriboonpaisarn. Today I will present about management of ipsilateral femoral neck and intertrochanteric fractures. for the incidence of the proximal femoral fractures right now is rising because of the aging society. And in this entity, the ipsilateral femoral neck and intertrochanteric fractures is about 4 to 7% of the proximal femoral fractures. It is quite rare, but increasingly recognized due to increased use of the preoperative CT scan. This type of fracture is combined between the intra and extracapsular fracture patterns, but it is frequently misdiagnosed about 20 to 30% as an isolated intertrochanteric fractures on initial radiograph. So the early CT evaluation is strongly recommended to identify this type of fractures to plan the fixation. And this type of fracture also have bimodal type. It occurs in two main populations, in high energy trauma in young adults and low energy fracturity fractures in elderly. So the characteristic of the combined between intra and extracapsular fracture patterns. Oh, sorry, the slide is not moving. So the combine between the intra and extracapsular component increase the risk of AVN, non-union, and fixation failure, because we have to treat the extracapsular component with securing the neck to leads to high complication rate if we try to treat it alone. And decision making between fixation and replacement is more complex than the standard hip fractures, which should be based on the age, bone quality, the displacement of the intracapsular fragment, and the viability of the femoral head. Right now, for the current knowledge gap, there is no unified classification of the ipsilateral fracture of the neck and intertrochanter. And we also lack of the high level of evidence for this type of fractures, which most literature consists of just case report or case series or mixed fractures cohort. For the optimal surgical strategy is still debated between several medullary nail versus diamond hip screw, and the last one is arthroplasty. For diagnosing, it's still the challenge because the occult femoral neck fractures cannot be diagnosed from just the plain film. And for delay or misdiagnosis of the femoral neck can increase the risk of non-union, AVN, and the operation. This is the case report of the 86 years old sustained a simple fall and left hip pain. The surgeon diagnosed as simple trochanteric fractures and underwent the diamond hip screw fixation. And the post-op film looked okay like this. And 10 weeks later, he still feel pain after follow-up, and the film come like this. So we can see that there is the displaced femoral neck fracture that we cannot see on the plain lithograph on the first film. So for recommendation of the imaging strategy, only the plain AP pelvis and cross-lateral table is not sufficient for the diagnosis. So we need the CT scan with 3D reconstruction in all suspected cases such as severe comminution or reverse oblique trochanteric fractures. It can help detect the occult femoral neck fracture using the CT capsular sign in this literature. They measure the capsular distension in the anterior of the femoral neck, which use the tangential line between the point connect between the anterior of the femoral head and trochanteric crest, and measure to the point of the anterior capsule border. They measure the difference between the two sides. If more than 1 millimeter, consider the sign positive. But still, the MRI is still gold standard for the occult femoral neck fracture detection. And for the classification, right now there is no standard classification, so usually described as the combined 31B and 31A fracture. And the recent papers propose that extend AOOTA 31A fracture based on 3D CT. And this type of fracture include as the type A4.4 in the red square in the right-hand side. This paper also proposed the classification of ipsilateral combined neck and intertrochanteric fracture in 3 types. The first one, type A, is parallel fracture line between the extracapsular and intracapsular, which found about 4% of all the fractures. And type B is the reverse oblique fractures with combined intracapsular fractures. This is the most common pattern that we found, about 95%. And the type C is the most rare. It looks like the femoral neck fracture Pauwel tree is very high vertical shearing fracture, which extend the fracture line from the intercapsular from superior to below the lesser trochanter. For the concerns of this type of fracture, for intercapsular component, it can disrupt the head supply, which increases for AVN. And for the extracapsular, it increases the instability from posteromedial fragment loss, which in combined patterns require more stable fixation and restoration of the calcar buttress. The fail risk is higher if you treat as an isolated fracture. So the principle of surgical fixation, we need the anatomical intracapsular reaction to preserve the femoral head viability and restore the anteromedial cortical support to achieve the mechanical stability. We should also assess the bone quality, as the osteoporotic bone may favor more intermediary fixation or arthroplasty. For the options from my research of the researcher, there are 4 main options. The first one is dynamic hip screw with or without augmentation of trochanteric stabilization plate and anterior tension screw. And the second one is severomedullary nail. The third is locking plate construct. And the last one is arthroplasty. For the first option, the dynamic hip screw, it can be used in the stable combined patterns. The advantage is a control collapse and it's simple to use. But still, you need to use the supplementary fixation in unstable patterns such as the anterorotation screw and the trochanteric stabilization plate or wiring. There is one literature from about 20 years ago from Kai and colleagues reported as high as 25 failure rate from this fracture type, but they only use just dynamic hip screw with no augmentation. And this is also the sample case reported that use dynamic hip screw. In the literature, they used wiring of the lesser trochanter and greater trochanter to augment the fixation and achieve union. The second option is a severomedullary nail. It's a single implant for inter and extracapsular fixation. There is 2 case series that report about 85 to 88% union rate. This is the first one. They used PFA2. And this is the second one. They used gamma 3 nail with U blade leg screw. It's a just third gen severomedullary nail. For the third option, the locking plate constructs, which are quite rare in the case series reported, mostly reported in the high energy fractures. And they say that the advantage is the multiple screw at the proximal can purchase the head fragment and control the rotation better. But you need to dissect the more soft tissue. This is one of the case report that used locking plate of the proximal femur. And this is also the case that used the proximal LCP. And they achieved union in 1 year follow-up X-ray. And the third one, this is the 38 years with Pipkin to fracture dislocation of femoral head and transcervical neck and trochanteric fracture. They use the reverse contralateral distal femoral LCP and cannulated screw, which also achieved union at 1 year post-op with no complications. For the last option is arthroplasty. It includes the hemi arthroplasty and total hip arthroplasty, with or without the trochanteric reconstruction, with wiring or trochanteric grip plate. It's indicated when the intracapsular fragment is displaced in the elderly patient, or if they have the current hip pathology in high age patient. This is a case report from the literature. They used bipolar hemi arthroplasty with trochanteric grip plate with wiring, which also report a good result. This is the most population that I find in the literature which compare the three options of the fixation. They say that the outcome is not much different, but different is the cephalomineal is shortest operative time and lowest non-union rate. The dynamic hip screw has higher failure and styling, and arthroplasty has similar complication rate but longer operative time and blood loss. So what should we do between fix and replace? You should fix if the patient is still biologically young and age less than 65. But if the patient is biologically old or severe osteoporosis and displaced intercapsular fracture, you should consider the replacement. And this is the proposed algorithm from the literature that propose the classification in 3 types. For type 1, if you should focus on the displaced femoral neck. If not depressed, you should go to fixation. But displaced and old, you can convert to a replacement. And in the second type, it's almost the same, but the option of the fixation, they prefer the cephalomineal too, not just the dynamic hip screw. And for the type 3, you just treat like the Pauwel 3 femoral neck fractures. The complication rate is the first one is neck non-union or avian. If you have done the surgery early and have good reaction quality, the rate is lower. And the second one is mechanical failure because you have no anteromedial support or poor implant position. And the misdiagnosis, which can be fine if you have no preoperative CT scan. For this type of fractures, you should always suspect in the intertrochanteric with fractures with a typical pattern, and CT is mandatory. And for the reduction quality, I think is important, more important than implant choice. And the fixation must restore the calcar buttress and neck alignment. And arthroplasty is still a valid option if the patient is still elderly. Thank you.
Thank you. Okay, this is one of the difficult fractures. May I ask? Okay, question, Dr. Hat.
Is there any, thank you for a good presentation. Is there any correlation between the age of the patient and your recommendation? Because in my experience, a young patient and elderly patient is totally different injury. So for your review, is it only for the elderly patient or both the elderly and the young patient in the high energy trauma?
In the literature that's included in my review, they include both of the young and elderly, but there's still some of the literature that review only elderly. But in the one that compare the 3 fixation and arthroplasty, they include the younger patients too.
So do you think, in your opinion, after your recent review of the evidence, do you recommend what is your, is there any, my question is there any difference between young patient and elderly patient in the treatment of this fracture? Yeah.
Okay, thank you. For the younger patient, I think we should go to the fixation only.
Yeah, I mean in the surgical technique or the implant choice, you know, because in I think I recall that in the Kim classification or the review, the mean age is more than 80 years old.
Yeah.
So I think it's only for the elderly patient. So what do you think? Is there any characteristic or any treatment that is different between the elderly and the young patient in this?
I think in young patient, the fracture is more higher energy, and the displacement and reduction should be harder than the elderly. And you mean like the implant options or?
Yes
I think you can speak Thai and you can
ใช่
Thai as well. Yeah.
ในคนอายุน้อยกับคนแก่ต่างกันไหมที่น้องรีวิวมา หรือว่าก็เหมือนกันเลยเป๊ะเลยไหมหรือว่าหมายคือเรื่อง implant of choice หรือว่าเทคนิคการผ่าตัด
คือเขาก็บอกประมาณว่าเหมือนเวลา reduction อะไรเงี้ยมันจะยากกว่าเพราะว่ามันพวกนี้มัน energy มันเยอะกว่าครับอาจารย์ แต่ก็คือ implant of choice นะก็หลักๆเท่าที่เห็นในเคสพวกเนี้ยก็คือถ้าคนอายุน้อยส่วนมากเขาจะ prefer ไปทางใช้ locking plate เพิ่มขึ้นมากกว่าครับ แต่ก็บอกว่าพวกdynamic hip screw หรือ cephalomyelin nail เนี่ยก็ยังเป็นออปชันสำหรับการ fixation ได้เหมือนกัน คือไม่ได้บอกว่าอะไรดีกว่าอะไรครับ แต่ว่าอยู่ที่ว่าเราคุ้นเคยกับ implant ตัวไหนมากกว่ากับตัว fracture configuration ว่ามันเหมาะกับอะไรครับ
พอดีของผมพอดีปีที่แล้วเฟลโลผมทำเปเปอร์นี้พอดี ก็นี้ผมแชร์ก็คือว่าของที่เราก็คือประมาณ40 กว่าเคสเนี่ยส่วนใหญ่ถ้าเป็นเดนมิคลิปกับโทแคนทริกเพลทจะเป็นคนจะ prefer ในคนอายุน้อย แล้วก็ open มักจะต้อง open reduction เพราะเป็น high energy แต่คนแก่เนี่ยมันจะค่อนไปทาง treatment คล้ายๆกับ intertroch เป็นหลักอันนี้มันก็จะแตกต่างกันชัดเจนเลยก็คือว่าเขาก็จะเทไปทางเนลเนาะพี่ว่าตรงนี้มันเราน่าจะไปลองดูเพราะว่าส่วนใหญ่เปเปอร์ที่น้องโค้ดมามันเป็นคนแก่หมดเลย
ครับ
มีแต่คนแก่แบบเต็มไปหมดเลยอาจารย์ต้นเชิญนะครับ
Just one question is young patient in the neck and trochanteric fracture together. What can you comment about proximal femoral locking plate is this a ideal fixation for this kind of fracture or you think it's not? Because you're showing us a good result, right?
Yes.
From the literature review.
There's quite limited report of using the proximal femoral LCP, but still, I think it's one of the options, but not the best one. I think, in my opinion.
I think, in my opinion, you should not use this implant in this kind of fracture because in the stroke fracture, you need collapse or fracture, some collapse. But the locking screw is not allowed to collapse. It's lock system. So it's a lot of failure rate of this using this implant, even in the intertroch fractures. This is my recommendation.
So I have one last comment. My question is that I want to comment that because if you follow the summary from you, so if we have this place, femoral neck, we would replace, right, in the last slide. So please, you have to distinguish between young and the elderly. Even in the young patient, if the femoral neck is displaced, we still fix.
Yes.
So please, when you make the recommendation, you need to,นึกออกไหม
Okay, thank you for your comprehensive comment. Okay, we move to the next topic. The peri-implant fractures of the femurs by Dr. Narusorn from Konkan University Hospital. Advisor is the Dr. Natthapat Uthaiwattananont MD. This is one of very common fractures, the peri-implant of the femurs. Please.
Right. Good morning, everyone. I'm Dr. Narusorn Wattakavanich from KKU, and I'm going to talk about the peri-implant femur fracture. My advisor is Dr. Natthapat. So what's the matter? Nowadays, there's elderly that getting treated with internal fixation device. So there are more chance of getting the peri-implant femur fracture. So it's new fracture pattern. And it's kind of like a new frontier of our fracture surgery. And by the definition for the peri-implant femoral fracture or PIF, it's a fracture that occurs in the femur that contain the non-prosthetic device such as plate, screw, or intermediary nail. And there are subset of the PIF, which is called the inter-implant femoral fracture, is the fracture between two existing implants. Why it matter? Because it's represent the intersection of biomechanical stress, the aging bone, and the implant. So we need to think just beyond the fracture line. We need to think as a whole bone biomechanic. For the biomechanic breakdown, of course, there are mechanical mismatch between the rigid implant and the elastic bone. So there will be a stress slicer at the implant end, and the shorter and the stiffer construct will increase the risk of the fracture. And in multiple implants, there will be unsupported bending zone, which is occur between the tips of two implants. And from the literature review, it will increase the cortical stress if the tip-to-tip distance is less than 110 millimeter. And you can see in osteoporotic bone, it will magnify this effect. And for the risk factor, we will classify into the host factor, implant factor, and the surgical factor. Host factor, just like elderly, female, osteoporosis. Implant factor would be like a stiffer, a construct, a short implant, and surgical factor would be like if we do an extensive approach, like periosteal devitalization will be like risk of the fracture. So for the classification, just like the previous peri-implant fracture, there's not a very specific one. The first one will be the NPPIF classification, which will based on the original implant, the position of the fracture, and the status of the original fracture. And for the next classification will be the EAGLE, which will define if it's a plate or nail, and the fracture, if it's in the tip of the implant, proximal or distal to the implant, or within the implant. And the last one will be the Videla classification, which is the newest one, but it will be a little bit complex, but it will tell more about a specific type of pattern. I think it will be useful for just like a research purpose. For the radiographic evaluation and planning, I think we need to do a full-length femur, AP and lateral, including both joints, to identify all the existing implant. And only for CT, if we uncertain about the loosening or the complex pattern of the fracture, the CT will come into place. What we need to evaluation will be the implant stabilities, the bone stock, and the osteoporosis. For the treatment planning, there are international consensus called PISCO, which I think it's the newest one. There are 4 principles. The first principle is the biologic respect. The second one will be inter-implant protection. The third one will be conservation of the existing implant, and the last one is protection of the femoral neck. For the first principle, the biology respect, we try to preserve the hematoma, the periosteum as much as possible. Try to use the Meeple technique with a locking plate with the low skew density. But the important thing is we need to still maintain the alignment in our plane. So if we cannot get the good alignment from the Meeple or minimal invasive, don't hesitate to open a bit to get the good alignment. And from the literature review, if we do treat this kind of fracture with Meeple technique and locking plate, there are high union rates, almost 100%, and a low complication rate. And for the second principle, the inter-implant protection, the main goal is to protect the gap between two implants. As I mentioned before, we want to avoid the inter-implant gap that is less than 110. And in the osteoporotic bone, actually we don't want a gap between two implants because it will increase the risk of fracture. So there will be a terms called preventive overlapping plate, just like in the right picture. And for how much should we overlap each implant, from the biomechanical study, it showed that we should overlap at least 6 centimeters between each implant, which will decrease the risk of fracture in the future. And the third principle will be the conservation of the existing implant. We want to keep what's worked to save the surgical time and decrease the morbidities. We only remove the metal hardware that would interfere the new fixation. And we only remove all the implant if it fail, loosening or infection. And For the last principle would be the protection of the femoral neck. We don't want to remove the several nail without indication because there are literature that report that the femoral neck fracture after removing the cephalomedullary nail is increased up to 14.5%. And in case if we have to remove the nail, they suggest to fill the defect in the neck with a bone graft or bone graft substitute. And there's a question in the consensus if for the naive femoral neck with the peri-implant femur fracture at the shaft, when should we extend the fixation into the neck? If the fracture is proximal to the long retrograde intramedullary nail or the distal DF plate, the fixation, we all agree to extend the fixation into the femoral neck. But if it's a short retrograde intramedullary nail or short DF plate, there's still no consensus whether if we put the new fixation into the neck, if it's going to be like worth it. As I mentioned, there's some literature that try to fix the in femoral shaft. They try to fix up into the head. They report that it's decreased the peri-implant fracture up to like 5 times. But we need to think about the complication or the increase the surgical time, the fluoroscopy, and the expense. So from what I've learned from this principle, I try to divide each scenario and the strategy of the treatment. So always follow the PISCO4 principle, and I will go for the previous implant if it extramedullary or intramedullary device. For the extramedullary device, if it's a short or a long side plate, for like example, for if it's a two-hole plate and the new fracture is tip or distal to the short plate, I think we'll agree that to remove and go for a long cephalomedullary nail. But if it's a longer plate and the fracture is at the tip or below the plate, we don't want to remove the plate. We would go for the long retrograde intramedullary nail and overlapping the side plate with the nail. And for the intramedullary nail, if it's a short and the fracture is occur at the tip of the short cephalomedullary nail, I think I would go for a long cephalomedullary nail. And if it's distal, very distal to the short cephalomedullary nail or a long CMN, the DF plate would be a good choice. And another entity is the inter-implant fracture. At first, I'm going to talk about the proximal nail and the distal plate or nail. If the fracture is between the proximal nail and the distal nail, I think it will be a bit of nightmare, but I think we need to remove both nail and go for a long cephalomedullary nail. And if it's between the two implant, I think the long bridging diaphyseal plate will be enough to treat this kind of fracture. But if it's a very distal, we need to remove the retrograde medullary nail and go for a DF that bridging the proximal nail. If it's between the proximal nail and distal plate, if it's around the proximal nail, we need to remove the proximal nail and go for a long cephalomedullary nail. If it's between the two implants, there will be a bit of go for a long DF and bridging above the proximal nail as well like the distal plate. And for the last one would be the inter-implant that will be between the proximal plate and distal plate or nail. If it's the fracture that occur around the proximal plate, I think we all need to remove the previous implant in the proximal part and go exchange for the cephalomedullary nail, plus or minus addition anterior plate if the gap is a little bit short. And if it's occur between two implant, between two plates, we can remove both plate and go for a long several nail or bridging the anterior plate. And if it around the distal plate, we would go for DF, long DF, or retrograde nail if possible. And the last category would be if it's occur around the proximal plate, I think there will be no choice but to convert to the lateral lock plate like reverse DF. And if it's between the two nail and plate, the anterior bridging plate would be come into the choice. And the last one, if it's occur around the distal nail, we would exchange for the long retrograde intramedullary nail or DF plate with augmentation. Thank you.
Any question from the floor? Please.
Okay, so I see that you talk about the protection plate, right?
Yeah.
So are there any safe distance between proximal and distal implant that you don't need to add a protection plate, or you recommend to add protection plate in all cases?
So from the literature that I review, if in like a good bone, normal bone, if there are gap more than 10 centimeter, we don't need to do the overlapping preventive overlapping plate. But if it's less than 10 centimeter, preventive overlapping plate would become in a choice. But we need to consider in like very high risk osteoporotic bone, they recommend to whether how the distance is, we need to prevent to use the overlapping plate to prevent the fracture.
Thank you for your presentation. So I have one question. Do you review about the solution of plate on plate fixation to solve this problem? You did not mention this or put it on your preferred techniques. Why?
Because actually for mostly in the literature, they only report about the peri-prosthetic fracture, and the peri-implant fracture is very limited in the literature that I try to research.
Are you sure?
น้อยกว่า polypost เยอะแล้วครับ
Paper from Taiwan, it is many years ago. It's a plate on plate. You know what I mean, right?
Yep.
Yeah. So it's like not a big series, but like a kind of 30, 50 cases. Maybe you have to go back and review it again.
Right.
I think it's one of the options that you should mention in your literature. Even they have a biomechanics study about this as well. Yeah.
Because yeah, I will go back and do more the research about the plate on plate.
Right. Okay. So in some circumstances, I mean, we normally use like unicortical screws or any kind of wiring. Do you have any good recommendation or any good practical tips for us, I mean, to follow?
Yeah, actually, for the bridging plate, they recommend to use the NCB plate that treat the polypost, and also wiring and the unicortical. If it's we cannot secure the fragment enough, so I think it's depend on if we can. I think the best way would be the bicortical. But if we cannot do the bicortical, I think the unicortical or the wiring would be come into place.
Right. I mean, I think the main concern is that we would like to try to protect like translation, for example, like the AP translation. So I think it would be good to keep in mind that we have to be able to maintain that one.
To secure.
I mean, if you cannot secure it by the unicortical, wiring is good option, but we have to calculate how many wires are going to be good for that.
Yeah, very good question.
Thank you for your presentations. I have heard you mention about the auto prefer method. It's quite variety. Could you summarize in a very simple term what are the principle behind the auto prefer method?
The principle For the general, I think the four principles of the Pisco will become in the place. And I think actually each patient we need to tailor into each type of fracture, but we don't want to we still want to protect kind of the main principle will be try to protect all the femur, both the femoral neck and both securing the new fracture that occurring. I think if you are very sure enough, if we can secure the fracture with different type of the implant, I think we can use many type of implant. But this is just like kind of like other preference that.
Thank you so much. Okay, then the next talk will be about the posterolateral tibial plateau fractures, the surgical approach and the outcome from Dr. Natthapat Uthaiwattananont from Nakorn Hospital. And his advisor is Dr. Warat Apiwattakagun. Okay, so I think that there will be a lots of comment in the next topic because very interesting talk, posterolateral. Okay. Okay.
Hello, test.
Yes, good. Ready to go? Okay.
Greetings, Chairman and Co-Chairman. My name is Natthapat Uthaiwattananont, and my advisor is Ajahn Warat Apiwattakagun. We are from Nakorn Hospital. Today, we're going to have a topic about the posterolateral tibial plateau fracture, the surgical outcome and the surgical approach and outcome. So let's get started. At first, we're going to talk about the prevalence and the etiology. The posterolateral plateau segment was involved around 63% in our tibial plateau fracture. The posterolateral lateral central was involved around 69%, while the posterolateral lateral segment was involved around 59% from the fracture mapping. The main mechanism of injury are combined of the axial loading, the valgus, and some degree of deflection. The posterolateral plateau or the PL plateau, why does it important? Because it provides bony containment and stability in the flexion. It has the joint contact surface and help in the load distribution. And it might associate that with a soft tissue injury, such as the cruciate ligament. But it is hard. In a prospective cohort study of the tibial plateau showed that the most mild reduction were located in the posterior part of the lateral plateau, especially the step deformity. And why that is hard to expose the PL plateau? Because they are consist of the PLC structure, as we show in the picture. They are the fibular heads obstruction. And even you can approach it when you're going to put the plate down, the neurovascular structure will obscure your direct bus tracing plate, as we show in the picture of the genicular artery and the anterior tibial artery. For the common PL plateau fracture pattern, many studies have proposed the characteristic of the PL plateau fracture into 4 individuals. The first one is a PL split, the second one is split depression, the third one is contained PL depression, and the fourth are the rim crush. This characteristic will help you choose the fixation method. Just imagine in the A picture, if you want to hold the fracture, you cannot put a single point to hold the fracture in. You need to put a palm, just like a palm in. So this kind of fracture will lose the containment. And the second one in the B picture, you can see that the apex of the fracture can be directly buttressed in a single point. So only direct buttressment is enough. So it will come down to the fixation of choice for the PL plateau fracture. The first one is the posterior buttressing plate, as we show in the picture. The second one is the rim plate that provide the containment. And for the novel PL stabilization technique, consists of the gel screw, the kickstand screw, and the lateral plating, which put a little bit far in the posterior part. For the picture of G and H, we'll show you that there are the kickstand screw, which insert in the inferomedial and point to the superolateral part. And the lateral plate will put a little bit posterior, just superior to the fibular head. And the picture on the right side will show you gel screw construct. For the surgical approach for the PL plateau fracture, we will divide it into two types. The first one is without the osteotomy, and the second one is with the osteotomy. Start with the approach without the osteotomy. The first one will be the extended anterolateral approach. The pros are we can do it in the supine or the lateral decubitus position. It can allow us to work to the anterior to the posterior of the lateral plateau. It can allow us to put on the lateral plate or the rim plate, and it's safer for the common peroneal nerve. For the cons, we cannot put in the direct butt tracing plate from this approach. It's difficult for the reduction. And when you do this approach, you need to make sure to flex the knee to loosen the LCL. And the exposure is quite limited. The structure at risk is conceived of the LCL, the popliteus tendon. For the exposure, you can see in this approach, we will see around this from Matthijs Kraus paper. And when you're gonna work with the extended anterolateral, you will work around this space underneath the LCL and the popliteus tendon and muscle. So if you make a good work and approach in this, it can provide you to put in a rim plate and a lateral plate as we show in the picture. If you can put 2 screws to secure the fragment, it might be enough in any literature. The next one is a Carlson posterolateral approach. This approach will be done in the prone position. It can provide you the direct exposure of the posterolateral, and it allow you to put on the direct posterior butt tracing plate. But the cons are you need to identify the common peroneal nerve. There are reports of the wound complication. It has steep learning curve, and the anterior column exposure is quite limited. For the structure at risk, it consists of common peroneal nerve. When you put in the butt tracing plate, you will encounter the inferior genicular artery and the anterior tibial artery. If your plate is longer than 2.5 centimeter to the 4.5 centimeter. And for the exposure, because we directly go through the posterior, the exposure will be like this. You can only access the median column only a little bit. And for the skin incision, you just approach over the fibular head, identify the common peroneal nerve, and you can see the posterior window like this. You can see the fracture, reduce it, and then put in the plate. The next one is a Frosch approach. You already see the posterior and anterior base approach. So the Frosch approach will combine these together. So we can do it in the semi-prone position of the lateral decubitus. It can allow you to have the 2 working window, and it can allow all kind of plate fixation. With the cons are still the same as the posterior base approach. You need to identify the common peroneal nerve. The learning curve is steep, and it can cause the iatrogenic PLC injury. And because we have 2 working windows, the anterior part we can also approach also, so it will become better exposure, but still limited by the skin incision. We make the same incision, but the patient was lying in the lateral decubitus. We open it, identify the common peroneal nerve, open the posterior window here. We reduce it, fix it, and then we open the next anterior window here. Then we put in the belt plate like this, or the rim plate. You can see that on the posterior window, we can also put in the screw. And this is a final fixation with the lateral plate. The next one is a modified Frosch. It is a development from the Frosch approach, because the Frosch will provide you a limit anterior column exposure. So they plan to increase the distal limb quite anterior forward, so it can give you more anterior exposure. With the cons and the structure at risk still the same as Frosch approach, but the wound might be larger. So the exposure might be very, very good exposure, but still limit in the some of the PLC segment because of the fibular head obstacle. So this is a case example of the whole lateral plateau fracture. We plan to make the skin incision. We go to the posterior first, and then we do the reduction and fixation with the plate. For the 5 the direct posterior approach. This approach can be done in the prone position. It can provide you the posterocentral exposure. It can allow you to put the direct butt tracing plate and the PCL avulsion fragment. But the cons are you need to go through the popliteal neurovascular bundle. It has high wound complication, and it will limit you to reach the far PLL segment. with the structure at risk of popliteal tendon and the nerve and vascular. The exposure that you will see will consist around the posterocentral segment like this. To do so, you will choose the proper fracture configuration to approach. You need to open the popliteal fascia first, identify the neurovascular, and then protect it. And then you will export the bone. And you will make the room for the plate in, and then you put on the plate, as shown in the picture. The next one is the approach without the osteotomy. The first one was the lateral epicondylar osteotomy. It is the extensile form from the anterolateral approach. It can provide you the better PL exposure. It can allow you to put the lateral plate or the limb plate. But for the console, you cannot put the direct posterior buttressing place. It also has the risk of the non-union, and it might affect the knee stability. The structure at risk also consists of the LCL, the popliteal tendon, and also its insertion when you do the osteotomy. And for the exposure, at first for multi-crowds, they have already done the research that only anterolateral approach can expose the posterolateral plateau around 36%. But if you do the osteotomy, you can export up to 80% of the whole posterolateral plateau. Just like the picture. To do so, you need to make the skin incision over the girdle tubercle to the lateral epicondyla. Then you export it, and then you just make a box cut over it, and then you can fix it up later. This is a case example that you can see in the G picture. It can provide you a good exposure. And the last one, fibula head osteotomy. We can done it in the semi-prone or the lateral decubitus position. It can provide you the excellent exposure and allow all plate fixation. But there are some cons. There are extensive soft tissue on osseous dissection. The risk of non-union. It might affect the knee stability, and it have the risk of the knee stiff with all the structure at risk that could be possible. So the exposure, you can export the whole lateral condyle. Lateral plateau from this approach. This is an example case of very bad injury of the tibial plateau fracture. Because of the fibula already fractured in this case, so we just go in, we go through the osteotomy, and we can see the whole lateral plateau. We reduce it and fixing it with a screw. In this case, it has very severe soft tissue injury, so we didn't decide to put the plate in. This is a conclusion table. In the case, you can catch up. And for the factor that involve the outcome are consist of a fracture configuration, the mechanism of injury, the associated injury, the quality of reduction, the mode of fixation, and the soft tissue dissection. For the outcome in the view of current evidence, from recent meta-analysis study on the approach for the PL plateau fracture, the least but lot, the least operative time, and the least complication are modified extended anterolateral approach. And the best functional outcome still the same as the modified extended anterolateral approach. But there are still lack of the randomized control trial study to prove this hands-on. So keep in mind that the fracture configuration will guide us to choose the approach. Take home message on the approach for the PL plateau. Always recognize the fracture pattern. Look at our associated column. And consider the bony avulsion fragment. Choose the proper implant and mode fixation. And always test the stability of the knee before and after bony fixation. This is my reference. Thank you.
Thank you. Is there a question? Please.
Okay. Thank you so much for a very good presentation. So my question is, you show us a lot of approach. We make a lot of confuse, maybe. So what fracture that you decide in the PL fractures that you're gonna use this approach, or you cannot use this approach, or which? There's the many factor, right?
Yes.
So you can use without or with osteotomy. So what factor of the PL fracture that you're gonna consider if you would like to use this approach? Or
to choose the approach, you need to, I think the main thing that you need to consider is 2 points. The first one is the mechanism of injury, and the second one is the fracture configuration. because the fracture configuration will guide us that this kind of fracture can be fixed by only the lateral plate or the rim plate, or it needs directly buttressing, especially in the wall fracture. You know that in the severely wall fracture or comminuted, the buttressing cannot be done alone. So you might need to provide the containment. So if you plan to use provide the containment, you need to open at the posterior side. So, but you don't need to do the osteotomy. You might choose the Frosch approach or the modified Frosch approach. But if the fragment is large and did not displace so much posterior, you can use the extended anterolateral approach to reduce it back to its prior position and fix it with the lateral plating. But always be careful when you choose to use the lateral plate. You need to put at least 2 screws to the fragment to secure it.
Thank you. So I think it's 2 factors about the fracture you need to concern. First one is limiticity of the PL, and the other one is the distal tension of PL. Right?
Yeah.
If you have a limiticity is not comminution, you can use without osteotomy.
Yes.
All right. But you have very comminuted, maybe you have to use the PL. But if you have the distal tension, you have to combine. You cannot use the PL approach alone. You need to combine with PM because you need to fix the distal tension with the long plate, and you need another approach. Yeah.
Okay, Dr. Chitubhi,
Yeah.
please.
So thank you for the very good presentation. I have seen in the conclusion table that you mentioned about the Gerdy tubercle osteotomy that you did not mention on your explanation. Do you have any comment about this?
Yes, this approach was first taught in 2007 from Shanya and Johnson approach. They recommend to do, there are 2 kinds of the osteotomy. The first one is only Gerdy tubercle osteotomy and flip it out. It can provide a good exposure. But from the original Shanya and Johnson, they just do cut into the anterolateral segment and open it up. It can help a lot in the central depression on the posterocentral depression, which is the blind spot. I can show you the picture, but there are a slide I hide.
Oh,
So
okay.
it can help you understand a lot
Understand.
about what I talk.
Because from the lateral epicondyl and the fibula head, we try to eliminate the LCL, right? But Gerdy is for the ITB, IT band.
Yes, this is from the Shanya and Johnson approach. You can see that they make the osteotomy through the intra-articular segment and flip it out. So you can see the whole through the posterior plateau. And there are so many studies in the Chinese. They also suggest to do the osteotomy in this part. But in my experience, I didn't see it a lot and it might complicate the fracture. So I decided not to talk about this in this presentation.
Okay. Another question is, when we compare this PL to the posterior wall fractures, very small posterior wall, we just leave it without doing anything. How about the size of the PL that we need to attack or we need to fix it?
In this topic, there are from my research, I still not found the conclusion, but there are some recommendation because of this lesion in some kind of injury we call the upper bite fracture or some reverse Bankart fracture. So I think the factor that might indicate is some small fragment that increase the slope more than 15 degree will cause this lesion unstable, because when you flex the knee, the femoral condyle will fall down into that defect. So you need to keep in mind that if the fragment even is small, but it have increased slope so much, when you flex the knee will cause instability. And also in the PL plateau fracture, there are concomitant injury, such as the ACL that have higher associated rate, around 70%. So this combined of the osseous and the ligament injury will result in knee instability. If the stepping, the patient can still walk, but if instability, the patient cannot use the limb. So I think you should take account on that.
So my last comment, well, this is the topic of the approach and outcome, but you just show the outcome only final slide. So I think that you may need to address the topic and find out the literatures which is review the outcome of the cases. So I think it's not enough. Okay.
Thank
Okay.
you.
Let's move to the next topic. About the current management of the ankle injury of the syndesmotic by Dr. Nuttapong from Nakhon Ping Hospital. His advisor is Dr. Pompong. รอดไหม
มันโหลดครับ เป็นเอาพอยมันโหลดค้าง
Okay. Okay.
Okay.
Okay.
Hello. Okay. Good morning, everybody. My name is Nattapong Pienthai from Nakhon Ping Hospital. Today I'm gonna present the current management for ankle injury with syndesmotic injury, and my advisor is Ajahn Pornpong. This is my outlines. So the distal tibial-fibular syndesmosis is like a main stabilization of the ankle joint. It has been injured in about 5 to 18% of ankle sprain and up to half of the operated ankle fractures. There has been report of 16 to 52% of syndesmotic malreduction across literature. And for standard treatments, there are many controversy issues, which we will discuss some today. And this is the anatomy of syndesmosis. It composed of 4 ligaments. On the front, it has the AITFL, and in between is the interosseous ligament, and on the back, there are PITFL and IOL. I classify the syndesmotic injury into two groups. The first is the injury with associated ankle fractures. The injury mainly is this injury mainly caused by the external rotated force to the ankle, as we see in the SER or PR group, and it's high incidence of syndesmotic injury in the Weber C ankle fractures to high as about 70%. And the second one is isolated syndesmotic injury. I used the 2015 ESSKA AFAS guideline to define this isolated injury. It's based on the timing of injury to the treatment. The first is acute for less than 6 weeks, subacute 6 weeks to 6 months, and chronic is more than 6 months. In the acute injury, it's further divided to the stable one and unstable. And for the unstable, they are latently unstable and frankly unstable. Acute stable can be treated conservatively, and the patient should be operated to get a good function. This is like a summary. The clinical finding, it is quite important to distinguish between acute stable and the latently unstable. For the stable, it has normal findings on both static and state radiographs, but for the latently unstable, you will find abnormality only in state investigation, such as state radiograph, weight-bearing CT scan, dynamic ultrasound, or test under arthroscopic. Next is the preoperative diagnosis of syndesmotic injury. We usually begin with the history taking and physical examination, as in other injuries. And there are many special tests to test the syndesmosis, as you are aware of. Others are important investigations, such as plain radiograph, ultrasound, CT scan, MRI, and arthroscope. This is a picture of some of the special tests. The first shows the fibular translation test, and the second shows the cotton test. If you find more laxity on the fibular or talar motion compared to a contralateral non-injured side, the test suggests a syndesmotic injury. The next is the pre-radiograph. We use 3 series, AP lateral and mortise view, and the full length AP lateral of the leg should be included to detect the high fibular fractures. There are 3 common parameters. The first is the tibio-fibular clear space, which should be less than 6 mm in both AP and mortise. The overlap should be more than 6 mm in the AP and more than 1 mm in the mortise. And the last is the medial clear space. It should be less than 4 mm. The B picture shows the frankly unstable syndesmosis. The pre-radiograph can help us to differentiate between the stable and the latently unstable by the state radiograph, as said before. There are weight-bearing, external rotation state tests, and gravity state tests. But overall, the static or state radiograph has quite poor sensitivity.
we can misdiagnose half of the syndesmotic injury case. The next is ultrasound. It is a non-invasive investigation. It can detect dynamic instability, but ultrasound is operator dependent and still not recommended by the guideline. But this picture shows ultrasound to detect the dynamic instability by using the probe pushing the fibula posteriorly, as you see in the picture B. The B2 show the displacement of fibula, which indicates the dynamic instability of the ankle. Next is a preoperative CT scan. It can detect three-pane syndesmosis. It is more sensitive than the radiograph, but due to wide variation of the distal tibiofibular syndesmosis, bilateral CT scan can use as an internal control to precisely diagnose syndesmotic injury. Nowadays, we have a weight-bearing CT scan to detect latent dynamic instability too. As in this picture, you can see for the AB is a quite normal mortise and the lateral view of the ankle, except there's some heterotopic ossification in the picture A. This patient underwent the weight-bearing CT scan, and we see the diastasis at the right ankle, indicate the dynamic instability. The next is the MRI. It has high sense and spec. It can detect ligament integrity, bone bruise, and osteochondrolesion. But please keep in mind that the MRI is static test. It cannot detect dynamic latent instability, which is quite important because it is our surgical indication. The last is the ankle arthroscope. It's regarded as the gold standard to detect the injury in an equivocal case from other investigation. It can inspect multiplanar assessment of the syndesmosis, but it's invasive and it needs surgeon expertise with the arthroscope equipment. Next is the treatment. We will focus the treatment on the already acute syndesmotic injury. They are non-operative and operative one. For the non-operative treatment, it can be done on the stable injury. We can follow this three-phase approach to treat our patients. The next is the operative treatment. There is two indications. The first is unstable syndesmotic injury, and the second is the syndesmotic injury associated with ankle fracture. For the fracture, it is the must that we fix the fracture anatomically to ensure the good syndesmotic fixation. And the goal of treatment is the anatomic reduction of the syndesmosis to ensure the better patient outcomes. For the operative treatment, we will talk about the intraoperative assessment, the reduction techniques, implant position, and the options. What is the best method? What is the best implant? Now there is still no consensus. For the intraoperative assessment, there are two techniques to detect the injury and assess the reduction. Either we do it directly or indirectly. We start with the most familiar sort of indirect technique, the intraoperative fluoroscope. We use hook test, externalization state test, or tap test to see whether the fibula is displaced more than 2 mm to indicate the injury of the syndesmosis. But this method already detects only the coronal plane instability, so it may be half of the case to misdiagnose the syndesmosis. And the fluoroscope has been a poor method for syndesmotic reduction assessment. There is report of high malreduction rate, especially when we view on the coronal plane alone. But in 2013, Mr. Summer suggests using the contralateral Tara dome view to compare the syndesmotic reduction quality to the uninjured site, which report quite a good outcome and reduction in about 17 to 18 patients, confirming by post-op CT scan. The next is the intraoperative CT scan. It's a powerful tool for evaluate the quality of reduction, but the downside is there is high radiation exposure and it's quite expensive, so it's not widely available. And there is still a question about time cost at a patient improve outcomes by using the CT scan intraoperatively. The next is the direct technique. The first technique is the direct visualization. By using the anterior incision to look directly at the distal tibial joint, it has high sense for the active injury and assess the reduction, which from the paper achieve good results in about 93%. The second is the direct palpation. By using the surgeon finger through the lateral approach to palpate over the distal tibial joint directly. This method can do both the diagnosis and assess the quality of reduction. There has been no difference in reduction quality from the literature between direct palpation and visualization. The last direct technique is arthroscope. Frankly, it can directly assess the syndesmotic integrity and reduction. There is a so-called arthroscopic bisulsa using the shaver to the medial gutter to detect the instability or syndesmosis. But this needs a special equipment along with the experience of arthroscopic skill. In 2025, Rushing had compared all of these techniques in cadaveric model to sequential sectioning of 1 to 3 ligaments. The result is that the direct technique are more reliable, and the most sensitive one is direct visualization compared to the rest. The next is the reduction technique. There has been many reduction techniques in the literature, but we simply put it into two groups, which are the cramp reduction and manual reduction. Cramp reduction is quite popular in the past, but it reports a mild reduction and overcompression of the syndesmosis. The manual reduction is quite a new technique by using surgeon thumb and hands to directly compress the syndesmosis together. It reports of less malreduction rate and at least equal or better postoperative radiologic outcomes. But the key is any technique combined with the direct assessment, we can achieve good syndesmotic reduction. The next is the position of the implant. In the 2025, Bartonisek proposed the insertion point of the implant to 3 parts. The first, it should be 20 or 30 millimeters above the joint. Second, the entry point should be at the lateral malar ridge, which is the bone ridge at the lateral part of the fibula, as you see in the picture A. And the third is the insertion angle. It should be parallel to intermalar line in the axial plane and parallel to the joint in the coronal plane. For the implant options, there is static and dynamic fixation. The first is a strong rigid screw. From the literature, 3.5 or 4.5 millimeters, 3 or 4 cortex has no difference. But the patient had to delay weight bearing, and nowadays the on-demand removal is better than the routine removal because we can less the cost of the second operation, and there is no second operation related complications such as infection. And the second is flexible suture button. It allows physiologic motion, and patient can early weight bearing, and the implant can be retained unless there is soft tissue irritation. This table shows the outcomes between syndesmotic screw and the suture button. The suture button show better early 6 months outcome, but equally on the long term. And the suture button can weight better faster, less malreduction rate, and less implant removal rate. But surely it is quite expensive. Yeah, and this is my suggestion for the syndesmotic injury. We do the periograph first, then go to stress. In the high case with suspicion, the patient should undergo MRI or arthroscope. And this is the recommendation for the fixation. We usually do the indirect technique first, but in highly suspicious case, we should do the direct technique. And we do the syndesmotic fixation if the test was positive by manual compression and reduction assessment by using the direct technique or the fluoroscopic on the both coronal and distal plane. Then I suggest to suture button fixation if there are no economic problem. Thank you. This is the end.
Any question? Please tell us.
In your slide, you mentioned that the syndesmotic screw maybe 3 or 4 cortices, right? What is your recommendation? We do not have our decision at this moment.
Yeah, there's still no consensus, but myself, I put just only three cortex. For a reason is sometimes say that it's maybe less breakage of the zoo, but in the long term, it's not quite significant clinically.
Okay. About the associated bone knee injury, are there influence to you to choose the type of fixation to syndesmotic joint or not?
I review this said that the most important part is to reduce the fracture as best as possible, and we can use both the screw and the button, but I did not find any literature to suggest about like the implant option upon the fracture configuration. It may be, but maybe I have to deep down harder.
So during the preoperative period, so do you recommend gravity stress test or not?
It actually has very less sensitive, but we can simply do it because it's just technique. If it's positive, it may help, but if it's negative, we still cannot rule out the injury in the
Okay,
suspect.
but I heard it differently. I think from the late report, they said that the gravity stress test is too sensitive. Like it just leads us to surgery with unnecessary in some case. Most of the time, they just recommend us to wait and maybe a week to do weight bearing. That would be more accurate to access this. And about the suture button, seems like you really like this one, right?
No, myself, I not usually use the button, but I review the literature. It's like there is more good results in just the short term, but for long term, it's quite comparable. Yeah.
Any downside of this one compared with the syndesmotic screw, other than just more expensive or less expensive? I mean, in terms of like strength and
there's some biomechanics study that maybe the button is not quite strong enough, even compared to the normal syndesmosis, just not the screw. That's about concern about the strength of the implant. Yeah.
Okay, just to add up, so the suture button is quite popular, but lately even the foot and ankle guys start to concern about its ability to control sagittal plane stabilities or rotational, right? So they tend to have to like open and repair ligament just to add stability. So maybe it's not cheap anymore if you add this thing up into the solution. But we still have to wait and see, all right? But it's not far more superior than the screw. So there have a pros and cons on each approach.
One last question,
Yes,
please.
thank you. Thank you for your excellent talk. So do you recommend to remove the syndesmotic screw? If yes, so when?
From the literature, now there's trend toward not routine removal of agent. It's like routine because the long-term follow-up in the retained group or the not or the removal one is quite comparable, and it can decrease cost of the secondary operation and also the secondary operation related complication, which is the life space in that it may be like the wound infection.
I think one thing is you need to concern if you do the early removal of the screw, you might have a instability of syndesmotic. That is a one of main concern of this screw removal.
Yes, and if you not remove, you have to talk about with the patient, like if it's late fracture of the screws, and they see it in the X-ray, the patient is
It
still
doesn't
very happy
matter.
with what they have.
Just inform the patient.
You must have to.
Okay. Okay. Thank you so much for your excellent talks. And the next we'll move to the polytrauma management. So we'll begin with the first talk with Dr. Nat from Ramathibodi Hospital. He will talk about the update in management in pelvic shock at presentation. Okay. I think Dr. Rahat is ready for comment. Okay.
Good morning, Professor and everyone. My name is Nat Phinitkitanan Fellow from Ramathibodi. Today, I would like to talk about update in management of pelvic fracture with shock at presentation. So let's start with the outline of my topic. In my topic, I will cover 5 parts: introduction, clinical assessment, management, then algorithm of management, And finally, system optimization and future direction. The pelvic fracture occur in around 3 to 8% of major trauma and around 15% present with shock. Mortality can rise to 50% in unstable case. And most patients have the associated injury, especially in the thoracoabdominal injury. Early death usually within the first 4 hours and often from massive retroperitoneal bleeding. When we look at the source of bleeding, about 80% to 90% come from the venous plexus, and fracture surface only 20% from the arterial injury. And the retroperitoneal space can have about 3 liters of blood. The patient can be severe shock even without any visible external bleeding. Then the fracture pattern had also matter. For the open book or AP type, the pelvic is open up, so it has severe bleeding. Then the lateral compression type, the pelvis is caught in bleeding may be a bit less, but watch out about the bladder and urethral injury. Next, for the vertical shearing is often tear the artery around the SI joint. And the last is the combine is the multiple vessel injury and highest mortality rate. Next to the clinical assessment. First assessment, we should start with the ATLS principle. The key is to recognize the shock early. Most patients come to the hemolytic shock class 3 or 4 with low blood pressure and high heart rate and the conscious change. We look for the buoys, hematoma, molecular lesion or open wound or pelvic asymmetry. We palpate the tenderness and fluctuation. Avoid repetitive tests on compression or distraction test because it can cause the bleeding. And usually rectal and vaginal exam for rule out the mucosal tear or open fracture internal. And usually perform lock roll only after bladder is secure. Next, we talk about the investigation. For start with the pelvic X-ray, one simple AP view can confirm the high risk type of the pelvic ring injury. Do the FAST or EFAST to look the intraperitoneal bleeding, and remember, it cannot detect some of retroperitoneal bleeding. If the patient stable, go for a CT with contrast to define the fracture and look for the arterial blood. And finally, don't forget to send another basic lab, especially in the lactate-based deficit, to monitor shock and coagulation profile with COSMAT for transfusion protocol. After we initial assessment and investigation, the next step is management. The key of principle of management is to control the physiology before the anatomy. Most unstable pelvic fracture die from the bleeding and coagulopathy. So we apply this concept damage control resuscitation. The goal is to restore blood volume and physiologic stability and stop bleeding as quick as possible to prevent the lethal triad. This concept has the 4 main parts. First is the permissive hypotension. Second, balanced transfusion. And third, use of tranexamic acid. And fourth, the massive transfusion protocol. We activate this damage control resuscitation early when the pelvic fracture within the shock or need massive transfusion. For the first, permissive hypotension, we have to keep the systolic pressure above 80 to 90 millimeter mercury until bleeding control, and avoid to give the excessive fluid or large volume of crystalloid because it can dilute the clotting factor and make the acidosis worsen. If the patient has the head injury, we need to maintain the high mean arterial blood pressure above 80. Next is the balanced transfusion. We have to use the 1:1 ratio of packed red cell plasma and platelet. This approved from the trial from 2015, which show the better survival and less mortality from estrangulation. So instead of give just a red cell, we give all blood component early. Next is the tranexamic acid, antifibrinolytic drug. In the randomized control trial show that if we give the tranexamic acid within the 3 after injury, TR after injury, it can reduce mortality. And the dose is easy, just 1 gram IV over 10 minutes. The last protocol is to early activate massive transfusion protocol. We activate it early, usually when the systolic blood pressure stay below 90, or after 2 units of blood. Or if we expect ongoing bleeding, we should early activate this protocol. If we early activate this protocol in the right ratio, it will decrease the mortality and risk of coagulopathy. And while resuscitation, another adjunct keep the patient warm, replace the calcium after 4 units of blood, and avoid to excessive crystalloid and vasopressor use, monitor lactate base deficit and coagulation. All of this support the goal of DCR to keep the patient stable long enough for us to control bleeding and definitively. The other part is to how to immediate hemorrhage control. Once we restore the physiology with DCR, the next step is to damage control surgery to bleeding control and temporary stabilization. We focus on the simple and fast procedure such as the pelvic binder, external fixation, pre-peritoneal pelvic packing, angiography, and endovascular balloon. The first is pelvic binder is indicated for the all suspected unstable pelvic injury with hemodynamic instability. Is it the fast and the first way to control bleeding if we suspected? Apply immediately at the level of GT, and we keep it no longer than 24 to 48 hours because it can prolong use can cause the skin necrosis, muscle necrosis. And once the patient is stable, we have to convert to external fixation. And remember, should not overcompression in the LC injury because it can cause the fracture displacement or further bladder injury. Next is the external fixation. After binder, if the patient still unstable or you see the ghostly mechanical instability, we move on the external fixation. For anterior injury, such open book type, we can use supracerebellar or iliac case pin. For vertical shearing or combine that have the severe posterior instability, we need to may add the C-cam for better control. ECFIC is quick and effective and often used with the pre-peritoneal packing for maximal tamponade. Next, the pre-peritoneal packing is indicated for the patient with shock with fast negative and persistent hemodynamic instability. And how can we use it? We can approach in the funnel steel incision or low vertical midline to assess the space of the lesions and pack 3 or 4 laparotomy pad per side, right and left, lateral to the bladder and anterior to the sacrum, and usually remove it after 24 to 48 hours to decrease the risk of infection, and have to monitor about the abdominal compartment symptom. Next is the angioembolization. The next option is target the arterial bleeding, especially in the internal iliac artery injury. We consider embolization when the patient remains unstable after pelvic packing or ECFIC, or if the patient stable but CT show the arterial blood. This is the best option to do. It works the best when the intervention can come early, quickly in the 90 minutes. And the selective embolization is very effective to arterial control. Next, the final option is Libur or endovascular balloon. It's like a bridging option, not the definite control, like a cross cam and how it works. When we insert the balloon in inferior to the perineal artery and is distant, it decreases the perfusion below the balloon and maintain the perfusion at the central perfusion. The indication is limited and should reserve for selected case in the patient that's still shock and negative fast and cannot immediately go to the OR. And how about the algorithm? This is the algorithm of management show that you should start with primary survey and apply the binder immediately and start DCR. Then perform FAST or EFAST if positive, go to laparotomy. if negative, focus on pelvic breathing control. If the patient respond to the research, you can go to the CT and selective angiogram. But if the patient unstable, you go directly to peritoneal packing with or without external fixation and review as a bridging. The finally is the some about the system. First, the system optimization is if we had the hybrid OR, it will can do everything: resuscitation, surgery, angiography in the one place. And Japan and Europe did use this concept, and it's clearly improved and decrease the mortality. And the prognosis is good if we can achieve within the 60 minutes of the resuscitation. Future aspect, we focus on shift on the surgical technique to the system efficiency and early decision making. Use the technologies like AI triage or real-time hemodynamic monitoring and expand use of hybrid OR to decrease the time of hemostasis. And the take-home message is we should priority on the physiology before the anatomy, apply the binder early and remove it in 48 hours. Peritoneal packing is prefer the first line of hemodynamic unstable fast negative patient. Angioembolization profile to the only arterial control and review only a bridging, not definitive management. Thank you for your attention.
Thank you. Do you have any comments or question? Please, Dr. Lahat.
Okay, you mentioned that if you want to do angiography, it's 90, it's less than 2 hours should be the time to theater.
Yeah.
So how would you recommend which case for angiography or which case for peritoneal packing? What is your recommendation to choose?
In the early concept, it focused on the hemodynamic status of the patient, and if the patient is stable for CT, I think it can be CT with contrast for look definitive the fracture size and look for the arterial bud. But if the patient have the unstable, you have to go stent to the pelvic packing, and the arterial bleeding is only just 20%. And if in the trauma one center that can achieve the early angiography within 90 minutes, the CT and CTA is the best option to find the artery bleeding. But I think the new concept focus on the hemodynamic and physiologic status before shoot the management.
So I think you should because that means that if you don't have angiography, the patient will have a poorer outcome. Do you? I mean, if they need, what is the? I think you have to mention two things. One is the evidence that if you have a standardized protocol for each institution, it can decrease mortality. Because if you don't mention this, that means that if your hospital do not have angiography or the full hybrid, then it's the patient will have a poorer outcome, which is maybe not true, because I think the angiography and the packing is now still controversy, which is better. Okay, so I comment. My comment is that you should mention about the institutional protocol. This have many evidence that if you have a good protocol that is adapt to your hospital, this can decrease the outcome. I mean the mortality and morbidity of the patient. And I think for the decision between pelvic packing and angiography, there is evidence that if you do angiography early is the best for outcome. If you do late, maybe it does not change the outcome. So I think you should mention how do you do do you detect arterial bleeding? So what is your recommendation? What is the clue that will tell that in this patient have arterial bleeding, and then you should do angiography? Do you have any suggestion for that?
I think the fracture configuration is the one factor that can tell us that patient have the artery or the venous, because if the patient had the vertical shearing, severe displacement or combined mechanism, it usually have the arterial injury.
Should mention about what is the sign from the CT scan or whatever that you can see.
Oh,
You can think about the arterial bleeding than the venous bleeding.
in CT,
It's not depend on the fracture pattern, I think.
Sorry, in CT view we see like the arterial bus from the CTA. So if we see the arterial bus, it means this patient have injury in the artery.
I can make some summary for you. So it's a fracture pattern, and those things you mentioned is true, but it's not entirely 100%. So there is a paper from JOT, I think it's often quoted by the trauma surgeon. There is a factor associated with the pelvic related arterial bleeding. You can go look. Is in a JOT 2014. There's many factors like systemic blood pressure and many of the blood lab. Okay, and then there's also hypotension at admission, which is your topic, right? And then there is also extravasation from CT angiography. And lastly, if you don't do the CT angiogram, you can calculate the pelvic blood volume from the normal CT scan. So I think this should be included in your decision making.
Other thing is I would like to add is genetic patient. You have an elderly patient who has hypovolemic shock. You have to think about the arterial bleeding than the venous bleeding.
Yes, all this factor, I can send you the paper. It's in this paper and the age and everything. So you can look.
Thank you for the comment.
Thank you for your additional comment, and further scientific reading is needed. Okay, so we'll go to the last talk of the morning section, the detection and monitoring of technique of the acute compartment syndrome by Dr. Panachol from Chonburi Hospital, and his advisor is Dr. Panachol and Dr. Sirawit.
Okay, good morning, everyone. My name is Panachol Leangtanom from Chonburi Hospital. Today, we'll be discussing a critical emergency in polytrauma management about the detecting and monitoring techniques for acute compartment syndrome. So first, a brief recap, what is a compartment syndrome or ACS? It is defined as a rising of pressure within a confined muscle compartment to a level which lasts for a duration sufficient to cause tissue ischemia. And this is not a condition that we can wait and see. This is a true surgical emergency, and any delay of diagnosis and treatment will lead to the reversible outcome. So the pathophysiology of ACS, we'll go so quickly, is a very vicious cycle, is starting from the trauma and cause the bleeding and edema, increase the pressure inside the fascial and obstruct the venous and lymphatic outflow and compromise the capillary arterial inflow. So tissue will get ischemia, and the feedback loops make it more worsen and get a cell death and muscle necrosis. So clinically, we are all taught to look for the classic sign, right? The most important and earliest sign is a pain out of proportion and pain on passive stretching. However, the study showed the sensitivity of these signs are as low as 13 to 19%. As you can see, the clinical exam alone is at the pitfall. So for high-risk patients, such as the unconscious, the neurological injured, the intubated, the clinical exam is effectively unusable. So if you find a full classic sign, diagnostic accuracy is up to 98%, but sure, is indicate a very late diagnosis. Because of the clinical exam is so unreliable and there's no gold standard yet, the guiding principle must be when you're doubt, you go measure. So the widespread practice, we look for a delta P or a perfusion pressure, which is patient's diastolic blood pressure minus the intracompartmental pressure. The delta P less than 30 millimeter. Oh, sorry. Millimeter of mercury or continuous measurement trends upward for up to 2 hours is indicated ACS and fasciotomy is needed. So let's explore the technique. There are 3 categories: invasive, non-invasive, laboratory, and let's go to the first one, invasive techniques. The current practice, we start with the most basic invasive method, right? Which everyone should know it, or the white side needle manometer. This is a simple, readily available setup using a needle 3-way stop clock and mercury manometer. We just inject a small amount of saline and we look at the meniscus is moved and read the pressure. However, the problem user dependent is prone to clog and inject fluid itself. It can falsely elevate the compartment pressure. So is important is just only the single time point pressure. So ACS is a dynamic process, and the single reading can be misleaded because we know it's our common practice. But significant improvement is the use of indwelling catheters similar to an arterial line. The weak catheter use the bundle of the proline white fiber to increase the fluid exchange to the surface and prevent the clogging, while the slit catheter use the slit at the end of the needle. Both are connected with a fluid field line to our external pressure transducer, and advantage there's continuous monitoring. But yeah, they can still clogging by the air bubbles and dampen the reading. Well, it brings us to the intra-tip transducer device, which include the stick and MEMS device that they put the pressure sensor at the very tip of the catheter. So and place it directly in the muscle. So it eliminates all the problems, the fluid lines, air bubbles, and clogging. And these devices are very stable and portable and provide accurate, continuous, real-time pressure trends. So 2025 trials found continuous MEMS monitoring, or in the picture, MY01 in the picture, it just 100% sensitivity and 97 specificity is allowed early diagnosis and prevent unnecessary fasciotomies. The MY01 in the red line show elevation of trends along the left front line, and while stick catheter, the striker, as you can see in the green label, the manual calibrator striker shows some limit observation, and the plateau line at the end of the graph about 30 millimeters mercury. And lastly, the stick catheter, the synthesis autonomate calibration shows the initial reading shift, which show falsely high pressure. And MEMS is the current trends of the high-risk patient monitoring. And the newer updates is multimodal sensor probes for detecting. First is the internal pressure in the compartment. Second is the oxygen saturation. And third is the flow rate relevant to the blood circulation. It was designed for easy insertion and cap removal. So they also found the consistency and reliability of the probe in capturing the real time in the data for in a Porcine model. The combination of 3 parameters that I've taught significantly reduce the misinterpretation due to the muscle contraction and external pressure. So let's look at the difference of the serial data point and the continuous measurement. We can see the green point of the serial measurement in every 4 hours and the upward trend from the green line. In contrast, in the same cutover, you can see in the red line show downward trends from continuous monitoring, which means there might be some false positive if you if we use only the serial monitoring. Well, secondly, we go to non-invasive techniques, which plays a safer role for the infection, right? This combined from two categories. First is microcirculation assessment, or we know this is the NIRS, is the most studies about the non-invasive method. So the device is placed on the skin, measure the tissue oxygen saturation in the microvasculature up to 3 or 4 centimeters deep. The theory is if the pressure rise, oxygen saturation will fall. Study shows 94% specificity and 72% sensitivity, means it can miss some case. It was affected by low blood pressure, dark skin, tattoos, and hematomas, which are all common in trauma patients. So we'll talk about several other techniques being explored to access the microcirculation. The contrast enhanced ultrasound in the first picture involves injecting the contrast and using ultrasound to visualize the muscle perfusion and is effective but impractical for the continuous monitoring and is require specialists. For second, the infrared image access the surface temperature with the ideal ischemic compartment will be get low temperature. This lack of clear diagnosis data. And the last one is pulse wave Doppler ultrasound. Look for the retrograde arterial flow during the diastole, which can indicate a high distal resistance, but data is limited in animal study. So the second is the tissue pressure from the non-invasive approach. A tissue hardness measurement, or they use a device called NCSE device, which turn the subjective palpation into an objective calibrated measurement tissue stiffness. A study report 97 sensitivity and excellent screening. It is excellent screening tools and specificity variable from 66% to 81%, meaning it have a higher false positive rate. And ultrasound pressure is combined from three methods, which is a shear wave elastography, SWE, in the first picture. They measure the shear wave velocity through the muscle, and they say the stiffer the tissue and the higher the pressure and the faster the wave travels. So this shows 93% sensitivity. And the middle picture, the pressure-related ultrasound measure the compressibility of the tissue under the probe. The ratio of compressibility less than 10% was found to have 95% sensitivity. And the last one, pulse phase lock loop, is another method that detects tissue vibration with a small pulse amplitude in case of the rising of the pressure. But these techniques are still limited in the clinical application. While finally, the biomarkers. The lab-based detection in this review is intramuscular glucose, which need to drop significantly in an ischemic compartment, but also intramuscular pH has also been studied, but results show it doesn't correlate reliability. So more recently, the serum biomarker are being investigated. 2024 studies found that elevated monocyte count, a high systemic immune inflammation index, and high CAKMB levels on the admission associated with a higher risk of developing ACS. This could be a powerful future tool for risk stratification. Well, to summarize all these techniques, let's look at the report sensitivity. As you can see, the early clinical exam alone is dangerously unreliable. And NIRS is a step up, but still only 72%. And non-invasive pressure, the standard method, like THM and ultrasound elastography or SWE, are very strong, and sensitivity is 90%, making them excellent screening tools. But current practice for diagnosis high-risk patient is continuous invasive monitoring with MEMS device, which approach 100 sensitivity. So the takeaway, there's non-invasive method are the future of the screening, but continuous invasive monitoring remains for diagnosis. Thank you for the attention.
Thank you. Please, Dr. Panachol.
Thank you for your information. To my knowledge, many years ago, I have read the papers concerning about the pressure. It has gradient of the pressure from the interior side to extend declining far away from the location.
Yeah.
So in case that we want to monitor, is it necessary to have multiple size of the probe to insert into the compartment that we want to monitor?
Okay, that's great question. Is actually already studies about the distance from the fracture site from in the compartment that we think it should be injured. It said is for 5. We have to place a probe in 5 centimeters from the fracture site in the compartment that we suspected. But in our practice, we use only the serial method, serial monitoring, right? We cannot put the continuous yet. In my knowledge right now, I don't know any college they have continuous or not. But if there's serial monitoring, there still need to measure all the compartment. In like the tibia fracture, we know that it can be high more. We found the compartment in the anterior aspect, anterior compartment as much as possible. But if we want to detect it in the serial monitor, we have to place check all of the compartment in 5 centimeters from the fracture side. But if we use the continuous monitoring, it has already studied that about that the any compartment, the rising of the trends will get in the same way. I mean, if the compartment is in the tibia, anterior compartment is the high pressure, and the interior compartment in the deep posterior compartment or superficial posterior compartment, there's still upward trends in the continuous monitoring. So if you ask me what I prefer, if we use the serial monitoring, we have to serial all of the compartment. But first, they recommend the first compartment that we measure is the suspected one.
The point that I would like to address is where is the location that will be appropriate?
5 centimeters
within
from fracture.
5 centimeters to the fracture, right?
Not within, is about 5 centimeters. If it's too close from 5 centimeters, it will be hematomas and it will be false positive. The paper said so.
Sorry. Okay. Thank you for excellent presentation. You make the boring topic to be fascinating. So I have, to be honest, in my practice, I never measure the compartment. If signs and symptoms are suspicious, so I undergo fasciotomy. So if signs and symptoms are obvious, but when you measure the pressure, the pressure is less than the limitation. So how do you decide?
Okay. If you mean the pressure is in compartment
Lower,
itself or
yeah.
delta P. If you mean delta P, which is diastolic pressure minus the compartment pressure less than 30 millimeter of mercury, and they said just only one time of measuring is not the diagnosis yet. It should higher, it should different. It should lower than 30 for 2 hours, which means first time if different is less than 30, you cannot stop and go to fasciotomy in that second, in that minute. they said is have to train the follow up the serial another 1 hour or 2 hours. He said if it's higher than occurs more than 2 hours is indicated acute compartment syndrome. So, but excuse me, but if you show the continuous measuring and you say the upper 10 for 2 hours, you can go fasciotomy. If
my question is, if everything support compartment syndrome, you still measure the pressure? Or are you
mean
perform
clinically?
fasciotomy?
You mean clinically, right?
Yeah.
Clinically, you go fasciotomy. No doubt to wait and see.
Okay.
If the clinical is suspected, you can go it. But Dr. Edward J. Howie, who written the compartment syndrome of the last Rockwood 10 edition, they have talked about this condition, and he said that if a suspicion, you can measure it if not delay the treatment, you can measure it and record it just for the legal issue.
One more question. I think still a controversy about in case that we detect the compartmental problem with delay presentation, like a patient come 12 hours later and we detect that it has some clinical compartment syndrome already. So what is the approach for delayed treatment in your review?
Well, for the delayed treatment, they didn't talk or studied about the timing of the late presentation yet. But if we suspect the late presentation, we can go fasciotomy, not more than 1 day, just only that. Just only they propose that only 1 day. But the timing, I cannot find the consensus about the delay treatment. But if it delay more than 1 day from the first first clinical that we can diagnosis for 1 day, this will be too late. The fasciotomy is not is useless.
Okay, one last question, please.
Sorry. Oh, if you done the serial monitoring as the result is data is 29, 78 for 2 hours, what to do?
For 2 hours? Well, yeah, it's less than 30, right? Let's go fasciotomy. But I have to say that we prefer
31, sorry, 31, 32 for 2 hours.
very hard. Oh, might be more serial because if the guideline, you know, yeah. Well, it's hard to answer this.
Is the law, right? But in reality, it's different, I think.
Yeah.
You have to balance between monitoring or whatever and clinical symptom, and you have to make decision. That is not true, always.
Yeah.
That depends on the number only. It's my point of view. Yeah.
ขออนุญาตคอมเมนต์นิดนะครับ คือ compartmental syndrome ที่เราเจอส่วนใหญ่เป็น acute case จะเป็นพวก injury อันที่เราจะไม่ค่อยได้เจอก็คือพวกที่เสพยาเสพติดแล้วหลับนานแล้วอยู่ในลักษณะที่นอนกดโดยเฉพาะอย่างยิ่ง area พวกบัตตอกหรือว่า dependent part แล้วพวกนี้มักจะ delay แล้วไม่มีแผลนะประเด็นก็คือว่าเมื่อไม่มีแผลแล้วมันเป็น compartmental syndrome แล้ว late detection เนี่ยก็มีลักษณะของข้อถกเถียงว่าเราจะไปเปิดทำ fasciotomy หรือว่าปล่อยไปเพราะว่าถ้าไปเปิดเนี่ยไอ้กล้ามเนื้อที่ necrose บางทีเราดีบรายไม่หมดหรอกแล้วมันจะ infect กับขณะเดียวกันปล่อยแล้วกลายเป็นลักษณะของ aseptic necrosis ของ muscle ที่เหมือนกับ Walkman contracture อาจจะเซฟกว่าอันนี้ยังไม่มีข้อสรุปนะครับที่ผมฟังมาเนี่ยผมถึงได้ถามว่ามีรีวิวมามีคนพูดเรื่องนี้หรือเปล่า
เท่าที่รีวิวไม่มีครับอาจารย์แต่ว่าเรา deep research เรื่อง acute compartment ครับอาจารย์ขออนุญาตขอแจ้งอย่างนี้ก่อนครับ เพราะว่า exertional หรือว่าพวก chronic อะไรเงี้ยอาจจะไม่ได้ deep ขนาดนั้นครับอาจารย์
เดี๋ยวขออนุญาตนิดเดียวขออนุญาตแพทนิดเดียวคือ
เชิญ
ยังจริงๆมีอยู่อิชูหนึ่งที่ผมคิดว่าน่าสนใจมากๆเลยคือว่าคือในทางปฏิบัติเนี่ยสิ่งที่เราเจอคือ fracture ที่มี compartment syndrome ประเด็นคือว่าเคสที่ไปทำ fasciotomy เนี่ยเราจะ internal fixation หรือว่า external fixation ผมว่าอันเนี้ยเป็นคำถามที่น่าสนใจมากๆเพื่ออนาคตนะครับ
ดีหน้าครับเดี๋ยวเลสไว้ครับ
ขอบคุณ
อาจารย์
ครับ
สุดท้ายแล้วครับอาจารย์ได้คิดครับ
เราถามนิดนึงไอเดียนะที่นายพรีเซนต์มา modality เต็มไปหมดเลยเนี่ย modality พวกเนี้ยมันเทียบกับ gold standard อะไรอะแล้วนายคิดว่า
ไม่มีครับขอโทษครับ
ไม่มีแล้วจะไปรู้ได้ไงว่าอันนี้มันเซนเท่าไหร่สเปคเท่าไหร่
โอเค อันนี้ก็คือเปรียบเทียบตอนที่ถ้าใช้ของเปเปอร์ที่บอกว่าเมธอดเขาดีที่สุดก็คือเปเปอร์ล่าสุดก็คือ 2025 ของเบมส์เนี่ยครับอาจารย์ก็คือ reference line ของเขาก็คือการที่ดัน pressure เข้าไปใน muscle compartment นั้นเลย ใช้เขาเรียกว่าอุปกรณ์ที่ดันแรงเข้าไปเลยครับอาจารย์ว่าดันแรงเข้าไปเท่านี้ pressure ตรงนั้นที่มันเป็น close pressure close compartment เนี่ยมันควรจะต้องมี pressure เท่านั้นตามอุปกรณ์ที่เขาอัดแรงเข้าไปอะครับพอเราวัดมันก็จะได้เป็นปริมาณตาม reference line ที่อาจารย์ถามครับส่วนคนอื่นเนี่ยถ้าบอกว่าเป็น false negative หรือ false positive ใช่ไหมครับเขาก็มีคน concern เหมือนกันว่าเราจะรู้ได้ไงว่าที่เราไปผ่า fasciotomy เนี่ยแล้วเราเป็น false positive หมายถึงว่าเราไปผ่า fasciotomy โดยที่ไม่ unnecessary fasciotomy อะครับรู้ได้ยังไงใช่ไหมครับเขาก็บอกว่าตัวคุณเอ็ดเวิร์ดฮาวีเนี่ยฮะเขาบอกว่าไอตัว muscle escape side ตอนที่เราลง incision ตอนลงfascia ครับตรงกรีด fascia ไปแล้วมันเห็น muscle escape side เนี่ยก็ถือว่าเป็น positive แล้วแต่ถ้าไม่มี muscle escape side เขาคิดว่าอันนี้เป็น false positive ครับ
คือไอ้ muscle accept sign ของนายที่บอกเนี่ยคือ muscle มันปริ้นออกมาใช่ไหม
ใช่ครับอาจารย์
แต่นายลองดู definition หรือว่าความหมายของ compartment syndrome นะ syndrome มันต้องมี sequelae ทีเนี้ยสมมติถ้ามัน escape หรือมันไม่ escape เราไม่ได้ treat เนี่ยมันไม่มี sequelae จะรู้ได้ไงว่ามันเป็น
คือมีเปเปอร์เขียนเหมือนกันครับอาจารย์ว่า sequelae ของมันจริงๆแล้วเลยอ่ะคือถ้าเราบอกว่าเราผ่าตัดช้าหรือไม่ช้ามันมีเปเปอร์หนึ่งที่เขียนว่าที่เขาเริ่ม propose ว่า2 ชั่วโมง 4 ชั่วโมง 6 ชั่วโมงตอนที่หลังไปทำ fasciotomy อะครับอาจารย์มันมี muscle necrosis หรือยังก็คือจะเป็นการเก็บพาโถชิ้น muscle ตอนที่หลัง fasciotomy treatment ไปแล้วอะครับแล้วก็เก็บพาโถไปดูว่ากลุ่มที่ fasciotomy 2 ชั่วโมงแล้วเก็บพาโถ fasciotomy หลัง diac 4 ชั่วโมงเก็บพาโถไงครับอาจารย์ก็เป็นการบอกได้ว่าถ้า fasciotomy ไม่เกิน 6 ชั่วโมงจะยังไม่มี necrosis ยังไม่มี muscle damage เลยครับอาจารย์อันนี้คือน่าจะตอบคำถามอาจารย์มากที่สุดเพราะว่ามันเป็นพาโถว่าทิชชูเนโครซิสหรือยังอย่างเงี้ยครับอาจารย์แต่ถ้ารอถึงจุดนั้นแล้วเราก็ไม่สามารถไป biopsy muscle คนไข้หลังเรา fasciotomy ได้ครับดังนั้นถ้าเราดู clinical outcome เลยจริงๆเลยก็ถ้า follow up ไปมี contracture ไหมหรือมีพวกloss function พวกนี้หรือเปล่านี่มากกว่าครับอาจารย์ถ้าเอาตาม clinical ครับ
30 วิให้อาจารย์เพชรเหลือเวลา30 วิผมต่อเวลาให้เป็นแบบไมเคิลลิเวอร์แล้วนะเนี่ย
โอ้คือพี่กำลังงงคอนเทนต์ที่น้องเขียนในส่วนที่เป็นไวท์ไซด์ครับน้องบอกว่าซาลายที่เราฉีดเนี่ยเป็นหนึ่งในตัวที่เพิ่ม compartment pressure แปลว่าน้องจะฉีดซาลายเข้าไปใน compartment เพื่อมันจะเป็นจะต้องฉีดเข้าไปเพื่อวัดเหรอครับเคยทำไวท์ไซด์ไหม
ไม่ใช่ครับเคยทำครับคือเราต้องใช้ fluid fill ครับอาจารย์ไวท์ไซด์เนี่ยมันคือ fluid fill ใช่ไหมครับตัวเส้นที่เป็น extension ที่แทงเข้าไปใน muscle ครับเป็นส่วนที่มีซาลายถูกไหมครับอาจารย์
ใช่
ส่วนคราวนี้ถ้าเรา pressure air แล้วเราเห็น meniscus move หมายความว่ามันจะมีบางส่วนของน้ำเข้าไปด้วยเขา purpose ว่าอาจจะมี false positive จากอันนั้นนะครับอาจารย์แต่ว่าความ meniscus นั้นทำให้เราอ่ะบอกว่ากลุ่มที่ใช้ไวท์ไซส์เนี่ยมันเลยเป็น user dependent ครับอาจารย์เพราะว่าบางคนบอก meniscus ไม่ move อันนี้ meniscus move
แต่เท่าที่พี่เข้าใจเนี่ยไอ้ water column นั้นน่ะมันไม่ได้โดน push เข้าไป
ควรจะต้อง fulfill เฉย
คือมันอยู่ในทิวบ์นั่นแหละเราดูแค่เรื่องของการโค้งเว้าของตัวคอลัมน์น้ำหรือการหยุดนิ่งของคอลัมน์น้ำแล้วก็วัดได้แล้วเราไม่ได้ต้องพุชน้ำเข้าไปข้างในพี่ก็ไม่ได้คิดว่าตัวซาลายเองจะเพิ่ม pressure หรอก
ครับ
ก็เลยกลัวต้อง clarify ก่อนเดี๋ยว
ครับ
กลัวว่าน้องแบบ
ครับ
ซัด
ผม
เข้าไปในคอมพันเป็นอย่างนั้นนะเพิ่มแน่ครับ
อ๋อครับ
เราไม่ทำอย่างนั้นนะครับ
โอเคเราดูมินิคัทเฉยๆครับอาจารย์
โอ
ขอบ
เค
คุณ
ครับเดี๋ยวผมโดน FA ร้องเรียนครับพอดีต่อเวลาโดนน้องโดนไปเกินไป5 นาทีนะครับขอคะแนนเพิ่มให้น้องด้วยนิดนึง ชนะก็ไปพรีเซนต์ต่องานโทรแท็ก โอเคครับขออนุญาตเรียนเชิญอาจารย์บรรจงครับ
ครับขออนุญาตใช้เวลาสัก2 นาทีนะครับจากที่ดูมาตั้งแต่ตอนเช้านะครับมี common mistake ที่ไม่ระบุชื่อคนที่เกี่ยวข้องนะขออภัยนะฮะเป็นลักษณะที่เราจะได้ปรับปรุงการออกเสียง trochanter นะไม่ใช่ trochanter คุณไปเปิดดูเลยนะมันจะเขียนตัว K นะไม่ใช่ trochanter นั้นฟังแล้วเนี่ยมีคนพูดผิดก็ไม่เป็นไรแต่ก็ถ้าหากว่าพวกเราที่อยู่ใน trauma ก็ผม address เรื่องนี้เรื่องเกี่ยวกับการใช้โคลอนนะครับลักษณะ punctuation หรือว่าเครื่องหมายวรรคตอนเนี่ยโคลอนถ้าหากว่าเราใช้เนี่ยมันเป็นลักษณะของการขยายตัวมันเองจะต้องไปติดกับคำที่อยู่หน้ามันไม่มี space นะแล้วก็ไม่ได้เอามาใช้เป็นตัวนำประโยคนั้นเนี่ยจะเป็นตัว dash หรือว่า bullet ส่วนตัว dash มีคนใช้เป็นไฮเฟนก็ไม่ว่ากันเพราะมันยาวสั้นเล็กน้อยไม่เป็นไรแต่จริงๆแล้วโดยหลักการต้องเป็น bullet หรือไม่ก็เป็นตัว dash ในการนำหน้าประโยคนะฮะอันนี้หลายครั้งเนี่ยเราจะเห็นว่ามีการใช้ full stop หรือ period ซึ่งจริงๆแล้วการใช้ period หรือ full stop เนี่ยมันจะต้องเป็นประโยคซึ่งปกติแล้วในการพรีเซนต์เนี่ยมันไม่ได้เป็นประโยคมันเป็นวลีเป็นนู่นนี่นั่นนั้นไม่จำเป็นต้องใช้นะครับแล้วก็เรื่องเกี่ยวกับไอ้ตัวโคลอนเมื่อกี้เนี่ยนะครับขยายความนิดหนึ่งว่านอกเหนือจากการที่เราจะไปหยุดหลังคำเพื่อขยายคำต่อไปเนี่ยมันไม่มี space แต่ถ้าใช้ในกรณีของสัดส่วนหรือเวลาจะมี space มันใช้คนละกรณีนะครับอีกอันหนึ่งก็คือเรื่องเกี่ยวกับcitation นะครับเวลาตอน present paper citation คุณจะเขียนเป็นตัวเลขแบบนั้นเนี่ยคนดูไม่รู้ว่าคุณใช้ว่าอันไหนนะคุณจะไปอันสุดท้ายเป็น reference แล้ว1 2 3 4แล้วระหว่าง paper ของคุณ1 2 3 4มันไม่รู้คือใครอะนะครับนั้นเวลาตอนเป็น powerpoint นั้นขอให้ระบุไปนิดหนึ่งก็เป็นชื่อคนที่เป็น first name และ et al แล้วก็เป็น journal อะไรที่เป็นหลักการโอเคนะไม่นั้นเนี่ยคนฟังเนี่ย confuse เพราะบางอันมี citation 3-4 อันแล้วแล้วตกลงมันคืออะไรครับขอบคุณมากครับ
ขอบคุณอาจารย์บรรจงครับผมขออนุญาตแอดออนเพิ่มนิดหนึ่งนะครับวันนี้ผมคิดว่าเราพรีเซนต์มาแล้วครึ่งวันเนาะจริงๆแล้วประเด็นหลักๆที่เราจัดงานนี้ขึ้นมาคืออยากให้น้องๆทุกคนได้ไปดูงานวิจัยและที่สำคัญสุดคือไม่ได้ดูงานวิจัยดูเรื่องของผลในการทำวิจัยในเรื่องของเอ่อเทคนิคใหม่ๆว่าแต่ละงานวิจัยเนี่ยมีเรื่องของผลในการวิจัยการเปรียบเทียบระหว่างเทคนิคใหม่ๆต่างๆหรือในบางอันที่เป็น innovation เนี่ย result ต่างๆเป็นอย่างไรบ้างฉะนั้นสิ่งที่เราอยากให้น้องทำมากที่สุดคือการอ่านและประเมินในเรื่องของความน่าเชื่อถือของงานวิจัยต่างๆซึ่งแน่นอนหลายๆหัวข้อจะเป็นเรื่องที่ค่อนข้างยังใหม่อยู่ฉะนั้นมันก็อาจจะเป็นในพวกกลุ่ม case series หรือว่าเป็นเรื่องของ innovation design ต่างๆซึ่งทำให้ได้ผลที่อาจจะยังไม่ถึงกับ promising ขนาดนั้นแต่แน่นอนครับเรื่องใหม่เราก็จะต้องมีข้อที่ควรจะต้องพิจารณาว่าเชื่อถือได้มากน้อยแค่ไหนวันนี้พี่คิดว่าอย่างน้อยอาจารย์หลายๆท่านที่ได้คอมเมนต์ในหลายหัวข้อก็มี add on เนาะเรื่องของ information ให้น้องไปอ่านเพิ่มเติมหรือไปค้นคว้าเพิ่มเติมซึ่งน่าจะได้คอนเทนต์ที่ดีเพิ่มขึ้นในเรื่องของหนังสือเนาะพี่คิดว่ายังพอมีเวลา postpone ต่อไปได้ก่อนครับ postpone คือน้องอาจจะไปรีวิวที่อาจารย์ add on ในเรื่องของน้องเพิ่มเติมนะครับแล้วเอาหัวข้อแล้วก็งานวิจัยตรงนั้นน่ะไปเขียนเพิ่มลงในหนังสือที่น้องจะส่งอาจารย์ประพลที่เป็นeditor เนาะลองไปทำการบ้านเพิ่มได้นะครับเพิ่มเติมประมาณเท่านี้เนาะเดี๋ยวอาหารอยู่ข้างนอกนะครับเดี๋ยวเราจะถ่ายรูปกันก่อนเนาะแล้วก็เดี๋ยวเราจะทานข้าวกันอาหารกล่องอยู่ข้างหน้าแล้วเราก็มาทานข้าวกันตรงนี้แล้วเดี๋ยวเราจะเริ่ม